All these things go in a negative manner, feedback mechanism after sleep, which improves reflects into the pancreatic beta cell mass. It reflects better insulin resistance or the modification in the body. This all helps because finally the hunger comes down and the satiation signal to the brain is better. So typically, if I have to tell you in a very I'll say very general person's words or simplistic language, the key mechanism of utility of your calorie, may it be fat or may it be sugar, is the insulin sensitivity. If something is going to improve that and something is going to improve it via multiple mechanisms, that is going to stay as the treatment over the long term with a long significant change, which doesn't happen with the caloric control, because that is something which will improve, which will stimulate the negative feedbacks and really gets the patient into a problematic zone where they cannot control their hunger and the satiety becomes a very, very difficult situation for them. Next. So there are bed-dependent mechanisms and there are bed-independent predictors of insulin therapy cessation, which are seen after surgery even before significant weight loss. म्हणजे पेशंटचं 10 किलो पण वजन कमी झालेलं नाही, पण पेशंटचं इन्शुलिनची रिक्वायरमेंट गेली आहे किंवा अँटी डायबेटिक मेडिकेशनची रिक्वायरमेंट गेलेली आहे. Almost 95% of patients who may be needing any anti-diabetic medication or insulin before surgery go home at the time of discharge without any need of anti-diabetic medication. And this is the fact, which is a globally noted fact. It works via the gut peptides, metabolic process centering. So the operation doesn't know fat or the sugar, the operation knows the caloric form. Not just glucose or weight centric, that is why it becomes a cardioprotective thing. Now the type 2 diabetes and the metabolic syndrome, all the treatments have shifted from glucose centric or weight centric into the cardioprotective centric kind of mechanistics, and uniform improvement in the glycemic control after any bariatric surgery is one of the important steps. Next, why the patient's glycemia gets corrected. Look at this, the early and dramatic post-operative improvement in the glycemia and insulin sensitivity, which is noticed after any metabolic surgery or bariatric surgery. It works via modifying the feeding behavior, via the gut-brain axis, via the alteration in the various gut peptides, as we said, and this is something which also changes the dramatic change, evidence is there which says about dramatic changes in the gut microbiota with a reversal from the obesogenic or the diabetogenic to lean profile. So you must be knowing that we are carrying huge amount of gut microbiota within us, which modifies the absorption of the calorie. And a lean profile is different than an obese profile. And this is what also changes after the bariatric surgery. Next. There are a number of other things also. I will not go into a lot of different discussions, but the vagal tone, which changes, and the sudden and sharp energy reduction, which happens in the body. This is something which reprograms the intestinal glucose absorption levels. And these patterns are the ones which help the patient come out of the disease pattern of type 2 diabetes. Next. Look at this, the kind of remissions which are seen with the intensive lifestyle and with the operations. Obviously, we understand that this is something which plays a different role than just controlling the calories in these patients. Next, how to predict who will come out? Because many of my endocrine patients have said to me patients which are like 150 unit dependency on the insulin for the day, or very highly diseased patients. So there is something which is called as the predictors of remission. Two groups are known. First group talks about the preserved pancreatic beta cell function, which includes the younger age, short duration of diabetes, and lack of insulin dependency. The second group talks about the insulin resistance, which includes the baseline BMI and amount of visceral fat or the fatty liver status of the patient. Next. So we are talking about now betterment of the sugars, betterment of the weight. Does it help the patient in terms of the long-term outcomes? Yes, for both microvascular and macrovascular outcomes. Interestingly, the predictors of remission talk about the prediction of the long-term significance of the vascular outcomes also. This is diabetes duration, degree of medication use, the glycemic control, the BMI, manifestation and severity of the other comorbidities. The more the severity, the more is the betterment you will experience. The C-peptide level, which are the indicators of beta cell activity and the age of the patient also. Next. Next. So now when we talk about these things, what happens to the adolescents? Because these are the people who are going to carry the disease or the problem for next many decades. It is seen that up to 99% of remission is evident in more than in adolescents at the end of even 5 years after surgery. So typically, they appear to have a similar weight loss with the, as compared to the adults, but better than adults as far as the remission of type 2 diabetes is concerned. So when to operate is also one of the important things. Surgical intervention helps, but the earlier the intervention, better is the outcome in the long term. Next. Next. So typically talking about the guidelines take into consideration the progressiveness of the disease. Next. And the intervention time both. Next. So recommendations are the bariatric surgery should be used as a treatment for type 2 diabetes in adults with body mass index more than 40 or maybe above 35 with any of the obesity related comorbidities. So for diabetics, it is 35 plus BMI should undergo surgery. And for Indians, typically 32.5 BMI with central obesity are the candidates who should undergo surgery because we have got very aggressive and progressive nature of type 2 diabetes. Even for BMI less than 30, it should be done in patients and the selected candidates who have got central obesity. This is important statement from the scientific societies which talks about the covering all parameters of metabolic syndrome, not just the glycemia or the weight. Next. Next. So there are some adjuvant therapies also. Next. Which go ahead. Next beta. So these are the different things which pre-exist already, but are not able to perform as significantly or yield as significantly as the bariatric surgery is. So that becomes the first level of treatment, and this becomes the now second levels of treatment. So these are various types of operations, and you can see patients have lost weight, patients have lost their central obesity, and patients have lost their all the dependency on the various medications for control of metabolic syndrome. Next. In whom, which operation should be performed is one of the big topics which we won't be covering in this time now. Next. Magesa. So these are typically patients. You are able to see that a patient at the age of 7 years who has come with type 2 diabetes, hypertension, severe obstructive sleep apnea, and weight 110 kgs is also a candidate who should undergo surgery because that becomes his survival issue in these patients. And you can see the other patient who is Dr. D.Y. Patil, as you all know him. He, at the age of 84, got operated for the bariatric surgery because of high dependency on the insulin, more than 100 units for the day, and multiple medication. Already angioplasty 3 times, 6 stents in C2, with the CRA element and everything. After surgery now, I operated on him when he was 76. Today he is 84 and still doing very well without any dependency on the multiple medications for metabolic syndrome. So age is not a bar. At any age you get a patient of appendicitis, the treatment doesn't change. Similarly, at any age you get the patient of obesity, diabetes, and metabolic syndrome, the treatments don't change. What we need to change is we need to look at the disease as such and not just treat his umbilical hernia or hiatus hernia or GERD or hypertension or diabetes or fatty liver or gallstones, etc. Like the joints or maybe the infertility problems. So typically, we need to improve our vision towards assessment of these patients and give them a good chance to live the life independent of the huge pharmacotherapy or independent of the huge lifestyle behavioral things which may not be possible with the bad metabolic or defective metabolic systems in the body. So remission should be the primary goal in the management and not just the control and maintenance. With this final statement, I take your leave. Thank you very much. Next. Thank you very much for the patient listening, and I hope it gives you some more insight when you are treating your patients. As I said, out of 5, 3 are deceased who need this kind of treatments, and we can help them actually.
Thank you, ma'am. Thank you very much. Weight also again because of the any reason. So, what is the impact of that? Whether this glycemic control is lost or what?
Very good question. The bariatric surgery doesn't talk about just the weight. It talks about multiple parameters. So when we count the outcomes or measure the outcomes, one is what is the loss of BMI. So if my patient comes from 160 kgs to 80 kgs and still with a higher BMI, I'm fine. Because as compared to day one, what is the loss of BMI, what we have achieved? What is the loss of fat percentage that we have achieved? What is the betterment in the comorbidities and the medications required? And the fourth part, which we do not talk a lot in our community in India, but it is the quality of life. So particularly if these things are maintaining and there is some weight gain, because body has a tendency to resist everything that we are going to work against. So there will be some weight gains, but all these things will remain same. Maybe I would say the sustainment of the pathological aid will be much better seen as compared to the weight. So people hardly come out with the recurrence of the disease, even though there will be 10% of the weight gain in over 10 years of time in these patients.
Thanks. Thank you. Thank you, ma'am. Thank you, ma'am.
Thank you very much.
Now I invite Dr. Pardhan sir for the lecture. He is a consultant physician and diabetologist running Pardhan Hospital at Srirampur. He is MBBS, MD, Medicine from VJMC, Pune. He has done many courses in diabetology from Australia, Denmark. He is attached to Sakarkanda Hospital, Srirampur. He is member of many national and international organizations of medicine and diabetology. His special interest is in semi-classical music, especially Marathi music. I welcome sir and request him to start the session.
Good morning. Let me first congratulate my friend, my batchmate, Dr. Ravindra Koti, for being the president of IMA Maharashtra State. I give him the best wishes for his future. Then let me thank organizer and team of the MASTACON for giving me opportunity to talk on very important topics, day-to-day topics, which is needed for the practitioner of all practitioners, I will say. Diabetes is a disease of all practitioners. It involves not only physician, but surgeon, gynecologist for GDM, pediatrics for type 1 diabetes, orthopedic and other people when their operated wound doesn't heal. So it's a disease of all pathy is diabetology or diabetes. And so when diabetologist prescribes some drug, you need to know what he's prescribing and you need to know what is the new in the diabetology. So I'm going to talk on the newer drugs. Dr. Pathak has already told the differences between new and old. What is new in Paris may not be new in India. So it takes little time for the drugs also to reach India. Nowadays, there is depatenting of many drugs like SGLT2 inhibitor and gliptins, which has poured drugs by pharma company in a Indian market. So you must be listening to them in your practice. This drug has depatented, which is now costing 50 rupees as start, is just for 8 rupees for your patient. So we'll see what are those drugs instead of going for a newer drugs which are in our practice. So diabetes is a global emergency, not only for India, but all over the globe. The people are people having diabetes. The population having diabetes has been increased. Currently, there are 53.7 crores people in the age group of 20 to 65 who has been diagnosed as a diabetes in last year. And diabetes is one of the fastest growing global health problems and emergency in 21st century. So there are 78.32 crores adults which will have diabetes at 2045. So this is a huge burden of diabetes. After I think COVID, this will be the pandemic or epidemic disease. Previously, the human beings that were affected by infectious or contagious disease. Now these are the communicable disease which has come in the coming to affect the human population. So the global prevalence is high, that's true. But in Southeast Asia, this has been increasing very fast, and around 74% is the increase in Southeast Asian people. What about India? India is supposed to be the capital of diabetes, but China is first one, then comes India. But if you compare the area-wise, we are still in number one. And the progression of the diabetes, the prevalence of diabetes is increasing in India faster than China. And next few years, we will be the first in diabetes. So there are 7.7 crore people of diabetes in India. But one more fact is that only about 50 to 60% people among the diabetes are diagnosed. So there must be around 5 crore people in India which are not diagnosed but having diabetes. In 2013, there will be 10 crores of the people, and in 2045, around 30 crore people will be there in India. So 43.9 people in the world, they are undiagnosed. In India, they are undiagnosed to have diabetes. So if you take 100 patients of a diabetes, only 53 are aware that they have diabetes, and 43 are unaware. Of that, only 79% or total of 42% they are treated, and after that, only 25% are controlled. So amongst the 100 patients, only 25% of the diabetes are controlled, good control. This situation may be worse in India. So with the increased prevalence, there is also increased burden of on the healthcare or increased financial burden of this disease for the India. In 2014, this survey has been done. We say that around per year, a patient needs to expend around 4,500 rupees, and the annual expenditure, you can imagine, there are 8 crores of people, and 4.5 into 8 will come a very huge amount. So India has a great burden of diabetic patients treated, great financial burden on our economy. In 5 years, it's about 50,000. 10 years, about 2 lakhs. This is the expenditure in 2014. May have been double in 2021. This is a main important slide of my talk. This shows how diabetes, what is the pathophysiology of diabetes mainly. If you know pathophysiology, you know how to treat the disease and what are the drugs available, how do they act. So first thing is there is decrease in pancreatic insulin. This we have learned and when I was doing my MD. There is either less insulin or insulin resistance which causes diabetes. But this scenario has changed totally, and now there is what is called as uptake or 8 different modality or 8 different paths which affects the diabetes, which causes diabetes. Maybe more than this will come in the next time. So first thing is there is decreased pancreatic insulin secretion and increased insulin resistance in a peripheral muscle. Then the next thing is there is increased pancreatic glucagon. So now it's a balance between insulin and glucagon, which maintains the blood sugar in the normal muscle. So both should be maintained. In diabetic, there is decreased insulin and increased glucagon. The one more pathophysiological mode is incretin hormone, which Madam has told. When we take some food, there are some hormones which are secreted by the gastrointestinal tract. They are called as incretin. These hormones, when released in the blood, they go to pancreas and secrete or increase the insulin secretion in the body. And this is how our blood sugar is maintained. There is also increased absorption of carbohydrate. If we take more carbohydrate, that is absorbed and which causes increase in the blood sugar. Next important is hepatic glucose production. Suppose you are in a fasting state, say after dinner, up to breakfast. In that time, our sugar is maintained by a hepatic glucose production. So when glucose dose goes down, the blood sugar is poured from the liver into the blood, and this is how the blood sugar is maintained. Next, and very important nowadays, is the renal glucose excretion. What happens in diabetes is, in a normal person, say around 180, when your sugar goes to 180 or above, then sugar is excreted in the urine and the sugar maintains normal. But in diabetic patient, this threshold is increased, say about 200 to 230, and renal and the kidney helps to increase the blood sugar in the body in a diabetic patient. This happens. And next one is peripheral glucose uptake, or what is called as glucose resistance and adipose tissue. So this is whole about diabetic pathophysiology. According to that, the drugs are developed. So when there is decrease in insulin and insulin secretion, the secretagogue drugs, which are called secretagogue, they are helpful, like sulfonylurea, glinides, amylin mimetics, and insulin itself injectable. When incretin hormones they decrease or they are degraded in the diabetes, that time the hormones, the drugs called as GLP-1 receptor agonist and DPP-4 inhibitors will see in detail. And when we want to decrease the carbohydrate absorption from the gut, the drug called as alpha glucosidase inhibitor like Oglyvos, Acargos, they help to decrease the absorption of the glucose in the intestine, which helps to maintain the blood sugar. Then comes the liver, which is very important organ in the diabetes. In this gluconeogenesis or glucose release in the blood is prevented by the drug called as metformin bile acid secretory. Next organ is the renal. In renal, we have seen that there is a increased threshold of the glucose in the diabetic patient. When you give a drug, what Dr. Pathak has told, SGLT2 inhibitor, that decreases the threshold, increases the glucose excretion from the kidney or in the urine, and maintains the blood sugar. So this one is independent of the glucose. The independent of the insulin. There is no need for insulin to act this drug. And the other drugs which improves the insulin resistance, like 5-glitazone, and one more drug which is called as dopaminergic agonist, like bromocriptine, that also help, but the exact mechanism of this drug is not known. So this is how these are the drugs in diabetic and pathophysiology. If you know these two slides, you know I think almost all the diabetes. The drug which was discovered first in 1920 was insulin for the diabetes, and this is the 100th year of discovery of the insulin. And after that, so many drugs has come in the market or in the for the treatment of diabetes. The main oral hypoglycemic agents, they are insulin secretagogue, as I told, they are glyclamide, gliclazide, epizide, and glimepiride. Non-sulfonylurea, they are ribaglinide. The trade name is Urepa, you must have. And then comes the insulin sensitizer, which increases the sensitivity of the insulin, like metformin, pioglitazone. The rosiglitazone is again coming in the market, which was banned previously. Then comes the alpha glucosidase inhibitor, which decreases the absorption of the carbohydrate, like acarbose, ogligose, and maglitol. DPP4 inhibitors are booming in the market now. They are almost conquering the diabetes anti-diabetic drug market, and they are like sitagliptin, vildagliptin, sexagliptin, and linagliptin, and teneligliptin. The AGLT2 inhibitors are like IMPA, Cana, and dapagliflozin. The other drugs like tamilantin, then bromocriptine, and so many other drugs, they are available, but they are not very useful. Then injectable is basic insulin. They are short-acting analog like glulicine of aspart and lispro. The short-acting regular insulin, immediate-acting like NPH insulin, and the new drugs which are coming in the market are the long-acting insulin, more and longer acting than intermediate or NPH which we are using, or lente insulin what we are using. So the long-acting are glargine, digludec, and datamine. GLP-1 analog, they are very good, supposed to be highest potency in all anti-diabetic drugs, but because they are injectable and they are costly, they are not being very commonly used. They are like exenatide, lexasinide, and liraglutide. So these are the drugs presently available in the Indian market. There are so many new drugs which are coming, like glucagon receptor antagonists, atherogenic antioxidants, then recombinant human glutamic acid decarboxylase, and so many I-level receptor, insulin action enhancer, GIP agonist, and adipose tissue signal. And there are also these so many drugs are still in the tanks, which will pour or which will come in next few years in the market. For the discussion, I have just chosen this drug like SGLT2 inhibitor, incretin, newer insulin analog, islet cell transplant, artificial pancreas, and the next was what was discussed by Madam was bariatric surgery, which is I think may not be a drug or it's just that. So first one is SGLT2 inhibitor. It's sodium glucose cotransporter 2 inhibitor. We'll see how does it act. This is the normal nephron, glomerulus, proximal tubule, distal tubule, and then collecting tubule, and the navy comes down. So in the proximal tubule, there are two main receptors, SGLT receptor, SGLT2 and SGLT1 receptor. These receptors causes this, they are responsible for reabsorption of the glucose. Whatever glucose is filtered from glomerulus, from the blood to glomerulus, which comes in the proximal tubule, that one is again reabsorbed in the body, in the blood, with this enzyme, which is what are called as SGLT2 and SGLT1. Now, this is only about 90% is by SGLT2 and just 10% are by SGLT1 inhibitor. So we need a drug which will prevent the reabsorption of glucose from the proximal tubule, and which will inhibit the SGLT2 and SGLT1. So SGLT2 inhibitor, these are the drugs which inhibit the glucose absorption from the proximal tubule, and because of that, that glucose goes in the collecting the and that will excreted as a urine outside. So most of the glucose which is not reabsorbed comes via urine outside the body, and the blood glucose is maintained. Now this action is independent of the insulin. These drugs do not affect insulin secretion or insulin degradation, either of these. So there is no need of if there is no effect on the insulin. These drugs are empagliflozin, dapagliflozin, canagliflozin. Is difficult to pronounce, so we'll just say empa, dapa, cana, remo, and zero, and tocogliflozin. These are the drugs. Out of this, empa, dapa, cana, and remo has come in Indian market, which is freely available. These SGLT2 inhibitors, they decrease.
Time, please. You can continue for 2 minutes. I know, sir, there is a time constraint.
No, but then I will stop here.
How long you can shorten?
Statements. No, already I have told what are the now. I think I will stop here. कसा होणार हो सांगा बरं.
You can continue for 5 more.
ये महत्वाचे ड्रग असतात अवेलेबल मार्केट.
Yeah, this is a newer drug. You please explain.
These SGLT2 inhibitors, they decrease HbA1c, blood glucose around 0.9%, and that is glucose independent. So even if when blood sugar comes normal, these hormones or these drug they do not decrease the blood sugar below the normal level. One more advantage is that decreases body weight, that decreases systolic and diastolic blood pressure, decreases uric acid, and they have effect on lipid. Bad effect is it increases LDL, but increases HDL. So these drugs are very important in treatment of diabetes. They lower blood glucose. They are also very useful in a cardiac patient. So many people say whether this is a cardiac or a diabetic or a renal drug. So these SGLT2 inhibitors, they are helpful in a patient of congestive heart failure, then early renal disease and diabetes. They are also cost effective, but they are not free from side effects. The most common one is as the more sugar is excreted in the urine, patient get increased genital mycotic infection, and there is increased urinary tract infection. Fortunately, in Indian patient, even though the personal hygiene is not well maintained, the chances of getting this infection are very low as compared to others. There is volume depletion because more urine, there is urination, and the patient may get hypotension, postural hypotension, hyperkalemia, if patient has renal insufficiency, hypotension, LDL elevation, and very worst side effect is euglycemic diabetic ketoacidosis. So if this drug is not used properly, patient get a diabetic ketoacidosis with euglycemia. Their blood sugar remains normal, but they get diabetic ketoacidosis. And there were some patients reported of blood cancer, then increased amputation with canal president, and and increased chances of bone fracture. But all these last three, they has been overwhelmed and they are not present now. Next one is incretin or hormones that has been secreted from the intestine by the K and L cell. When patient take a meal, this meal comes when it comes in intestine. The two main hormones, that is GIP and GLP-1, they are excreted in the blood. Then goes to pancreas and then they secrete or increase the insulin secretion. And one more important thing, that it decreases the glucagon production. This is very important. And this insulin, when goes to peripheral blood cells, that increases the glucose uptake. This also has effect on liver, which is main culprit for the hepatic outflow. This decreases the hepatic glucose output in the blood. So that what are the ingredients? They are the insulin, gastrointestinal tract secretes the hormone required to incoming nutrients and which stimulate insulin production. This is incretin. There are two types, what I told, the GIP and GLP-1. GLP-1 analog or GLP-1 receptor agonist is the first drug. This is secreted with the meal and other nutrients which activate GLP-1 and GIP. But the one main important is they are rapidly inactivated by the enzyme called as DPP4, and their half-life is just for 3 to 5 minutes in the blood. And with that, they causes insulin, they increases the insulin secretion. So if we have a drug which will deactivate this DPP4 enzyme, will increase the GLP-1 secretion in the blood. And it we have a drug, which GLP drug, which are not inactivated by DPP-4 inhibitor. That will be helpful to decrease the blood sugar. So we have two drugs, which one is called as GLP-1 analog. They are like GLP-1, but they are not degraded by the DPP-4 enzyme. And the second one is which inhibits the DPP-4 enzyme and increases the endogenous GLP. These are the different action of the GLP-1. They do not just act on the beta cells, but they have action on the brain, which decreases the satiety. So food intake is decreased. They also have action on alpha cell, which is the glucagon. These are the main GLP-1. Most of them, except one, are injectable. They are very costly. Digludec, liraglutide. But the important is this drug can be given once in a week. Q-week is once a week. Then exenatide, these two are given once a week. Exenatide plain is given twice a day. Lexacinide and albuterol, they are given once a day. This injection, like insulin, we need not to give it with the milk. We can give it at any time also. So approved drug exenatide, biotizatrenine, and emergent drugs are seraglutide injection. Then next incretin is DPP-4 inhibitor. So as we have seen, they inhibit the enzyme DPP-4 and it increases the active GLP in the blood, which goes to pancreas and stimulate the beta cell. So these DPP-4 inhibitors, they are oral rather than injectable. They are weight neutral. There are less chances of hypoglycemia or GI side effect. The most important side effect of GLP-1 is nausea, vomiting, then the diarrhea, or when GIT, they have adverse effect on gastrointestinal. But this DPP-4 inhibitor, they hardly have any adverse effect. There is no hypoglycemia if they are used alone. But if you use with the sulfonylurea or metformin other drug, the patient may get hypoglycemia. Then they do not reduce or increase the cardiovascular risk. This is more important because if you want to introduce any drug in any anti-diabetic drug, they first have to prove that this doesn't cause any adverse effect on the cardiovascular system and improves beta cell function. Main DPP-4 inhibitors are sitagliptin, vildagliptin, linagliptin, sitagliptin, evogliptin, teneligliptin, alogliptin. All except gemigliptin are available in the market. This table shows a comparison of the different DPP inhibitors. What is different is about linagliptin that can be used in a patient with renal impairment or chronic kidney disease. Other DPP-4 inhibitor dosing is given in the first time. It causes reduction of the HbA1c around 1.5 to 1.7 or 1.9% sitagliptin. The summary of DPP-4 inhibitor, they reduce HbA1c, then stimulate insulin secretion, inhibit glucagon, slows gastric empty, reduces food intake, improves blood pressure, improves inflammatory markers. They are weight neutral and good tolerant, and nowadays they are cheaper. So next group is newer insulin. The insulin has discovered early in 1920 and has shown many revolutions in the insulin proper. It was animal, then came human, and now analog, and now long acting. There was a limitation of the insulin which were used conventionally, like there was glucose excursion and hypoglycemia, what is called as glucose variability, which has been taken care by the newer analog insulin. This is one newer one, which is insulin degludec, then insulin glargine Q300, insulin degludec plus insulin aspart combination, rhizodec, which is rapidly capturing the Indian market. Then this is the faster acting insulin, which is called PS. The insulin which we were giving previously, we have to give half an hour before the meal. But the insulin which are given like PS, that you can give with the meal or just after the meal. This is the great advantage of this insulin. Then different combinations of the insulin and analog. So insulin aspart, lispro, and uliside is the shorter acting analog. And there is also mixed insulin. and a longer acting insulin like insulin database and insulin regulator. This shows their onset of action and peak level. The next one is oral insulin. Everyone is fed up of giving injection or taking injection of the insulin. And there is great phobia, what is called as needle phobia. So there is constant research going on for the oral insulin. And I think when it will come in the market, will be the wonder for the human beings. So what is the great hindrance in oral insulin? When you give insulin orally, that is degraded by different GIT enzymes and doesn't go in a portal way for the action. So we need a subsystem which will protect or which will degrade the production of this one, the degradation of the oral insulin, and will make available insulin for the action. The great research is going by our Indian company Biogon on the oral insulin. Then this is the new drug which has introduced by Torrent Pharma, imeglimin. This is totally new class, not included that octet, which I explained. It's a Japanese drug and it to be tested in a market. Then one more new drug is semaglutide. Is an oral GLP-1. GLP-1 I have told that we have to give injectable and they are costly. But this is the oral one. Orally you can do, but just you have to give it 30 minutes before first food and with a half glass of water. And there are less chances of nausea, vomiting as compared to other GLP-1. But the cost is around 370 rupees per tablet. It's very costly. It's still reach of the NMP. There are some synthetic analog or human amylin, sibilin. Just to next drug is a there are dual PPAR agonists. Next one is islet cell transplant, like a kidney transplant and other transplantation. There is great research going on islet cell transplantation. It's of two types. Auto transplant, that is the islets are taken from the patient himself and injected, and one is allo, that is from the donor. This shows how the islets are transplanted from the donor. The beta cells are collected or isolated. They are injected in the portal vein, and in the portal vein that goes to the different body organs and produces insulin. One next thing is artificial pancreas. If the success rate of islet cell transplantation is low, then why not to have artificial pancreas like a transplant? This is also called as bionic pancreas. It has dual chamber. One chamber says how much is the glucose in the body, and next one gives the insulin or glucagon. Next one is smart insulin, like insulin patch like this. They give the insulin patch on the body. This senses glucose level in the body and releases insulin in the body. This is called as smart insulin. Inhale insulin is the next one. Just it has to inhale like this, and that goes in the body. That's absorbed in the lung and goes in the body. Human insulin. The upcoming devices are coming up, and last one is diabetic app, which is very important. So many diabetic apps are coming in the market, which are helping the patient to improve their glycemic control and variability. So, with all the knowledge, treatment, and technology available, there is no reason why anyone should have elevated blood sugar level above normal. And it is still a long way to go before these drugs are widely available and affordable to Indian diabetes. Thank you. Thank you, Chairperson, for giving me a time.
Thank you very much.
I think we are nicely highlighted by Dr. Pargan. So we should excuse them for taking a time, but they are delighted with it. Thank you, Dr. Pargan.
Please stay on the desk, Dr. Pargan, sir. I request Dr. Tolkar, madam, please come on the desk. Pargan, sir, please stay on the desk. Session is open for question and answer. Any questions from the audience? I request Dr. Bade, madam, to felicitate Torkar madam.
I think आता आपण सगळं ऐकलं की the way diabetes is a huge disease and the way the pharma companies are going behind diabetes for control. हे जे काही सरांनी आता दाखवले multiple pathophysiological mechanisms and so many different kind of medications which can act via one or the other route. I think again I will come to the same point. Pediatric surgery has proven itself. This is not this is a scientific forum, so I'm talking very much with the science and the clinical evidences in hand. So pediatric surgery proves itself as one strong modality which can control all the pathophysiological mechanisms which are going on.
One thing I will say, madam, these are only helpful to the limited person whose BMI is more than 35. So
30.
other person whose BMI is less than 32.5, they need this medicine. So there is no authority for this.
Yeah, but I mean,
It will not cure pediatric surgery will not cure that.
yeah, but beyond the 30 BMI, yes, you can downgrade the disease to a huge extent, and I think that is very important because it's a lifetime disease.
I request Dr. Deshpande madam to felicitate Dr. Padgal sir. I request Dr. Sawan sir, Prashant Sawan sir, to felicitate our chairperson, Dr. Bade madam. I request Dr. Anase sir to felicitate Dr. Deshpande madam for chairing the session. Thank you, Bade madam, Deshpande madam, for chairing the session. Next is Symposium on Hepatitis B. I request Dr. Anase sir and Dr. Shirsat sir, please come on the dais for chairing the session. I request of moderator, Dr. Vaibhav Gandewa sir, please come on the dais. Other panelists, Dr. Ashok Moite, Dr. Ashok Moite sir, please come on the dais. Dr. Vinay Jawar, Dr. Dattatreya Goel, and Dr. Bhushan Dev sir. I request all the panelists to please come on the dais.
Good afternoon, everyone. At the outset, on behalf of all our panelists and by the team, thanks to Dr. Professor, and organizers for giving us this opportunity to make few corrections. For possibly the change in panel has not reached to the organizers. We have communicated to Dr. Professor. Instead of Dr. Ashok Moite, Dr. Rahul Talere sir is there, and Dr. Sandeep Palsing is there in the panel. So myself, Dr. Bhairobanjan, moderator, Dr. Bhushan Dev sir, Dr. Sandeep Palsing, Dr. Vinay Jawar, and Dr. Rahul Talere are in the panel. Dr. Bhushan Dev sir, he is MD in pediatrics. He is gold medalist during his 20 days. He is now guide and examiner. He has many publications to his credit, and currently he is working as professor and consultant pediatrician at Rural Medical College, Loni. Dr. Sandeep Palsing is MBBS, MS General Surgery, and DMB Surgical Gastroenterologist. He has special interest in hepatobiliary surgery, advanced laparoscopic surgery, GI surgeries, GI cancer surgeries, geriatric surgeries. He is consultant GI surgeon at GI Hospital, Aurangabad. Dr. Vinay Jawar, he is MD in medicine. He is DM gastroenterology from Private Medical College, Mumbai. He has also DMD to his credit. He has interest in advanced endoscopy and liver diseases. He is director and consultant gastroenterologist at GI Hospital. Dr. Rahul Talade, he is MBBS from BGMC Pune, MD medicine from Pravara, Loni. His DNB in gastroenterology from Asian Institute of Asian Institute of Gastroenterology, Hyderabad. And he is currently working as consultant gastroenterologist at Korean CTDF Hospital, Aurangabad. Myself, Dr. Vaibhav Jawar, I am DM gastroenterology from 2010 batch. I am presently working as consultant gastroenterologist at GI Hospital, Aurangabad. So to come at our main topic, hepatitis B. It's basically chronic hepatitis B. It's a major global healthcare problem. WHO has declared that its intention to eliminate hepatitis B by 2030, and to achieve this aim goal, the new chronic hepatitis B incidence should be reduced by 90%, and mortality because of the chronic hepatitis B should be reduced by 65%. So if you see at 2010, the total prevalence of the total population along almost 3.6% of the global population was HBsAg positive, and in 2016 it has increased to 3.9% from 248 million to 92 million. Almost 9 lakh people die from because of the hepatitis B or related to its complications. So if you consider about India covers around 10 to 15% of the global population of hepatitis B. So that is almost 40 million population from India is infected with hepatitis B. Prevalence in India is around 0.1 to 11%. Most of the studies have shown the prevalence from 2 to 8%. The prevalence is more in Arunachal Pradesh, Ladakh, Andaman and Nicobar. And prevalent mode of transmission is horizontal transmission during the childhood. Previously, it was mainly because of the unsafe injectable practices. So, coming to the hepatitis B virus itself, it's a virus from Hepatina family, and it has structural contents like nucleic acid, HBsAg surface antigen, nucleic capsid coat, which is the structural peptide, then circular DNA, and multifunctional polymerase enzyme. So this S antigen, it encodes for the hepatitis B surface antigen. Then core antigen, it encodes for the core protein, that is core protein and E antigen, and polymerase, it encodes for the DNA polymerase and reverse transcriptase activity. The predominant drug activity against all these transcriptase activity and DNA polymerase. X factor is involved in the carcinogenesis because of hepatitis B virus. So, main infective particle from the hepatitis B is Dane particles. These are other forms like spears and tubules. So, hepatitis B virus initially gets attached to the surface of the hepatocyte. Then it gets entry into the hepatocytes. Then viral uncoating, and then this virus DNA from the hepatitis B virus gets incorporated into the host cell DNA, which leads to transcription and then the multiplication of the viral proteins and assembly of the viral proteins inside the hepatocytes, and then these infective hepatocytes give rise to another viral antigens and viral proteins. So hepatitis B, whenever we are investigating, you should know various forms, like various investigations like hepatitis B surface antigen. It is the surface antigen, and it is used for the screening of hepatitis B, and hepatitis B positivity on 2 occasions 6 months apart, it denotes the chronicity of the hepatitis B. E antigen, it is envelope antigen, and it is a marker of infectivity in these patients. And hepatitis B core antigen, it denotes various types. Core antigen per se is not detectable as of now, but antibody against core antigen is important for the diagnosis in the diagnostics. Then E antibody appears after the seroconversion. It has 2 types. The core antibody has 2 types: IgG, which denotes the previous infection; IgM, it denotes the new infection. And then hepatitis B viral load, it is measured by the PCR, polymerase chain reaction, even RT-PCR. In the some technical issue. So presence of HBsAg denotes the diagnosis of hepatitis B, and its presence on 2 occasions 6 months apart denotes the chronicity. Hepatitis B virus is more infectious, 100 times more infectious than HIV. So coming to the transmission, Dr. Rahul, can you just tell us that is the modes of transmission for hepatitis B?
Am I audible? Yeah. So, hepatitis B behaves differently in the areas of different transmission and organism. So, when the prevalence is in the high, more than 8% range, and the intermediate prevalence and low prevalence countries. So, when the prevalence is high, the neonatal from mother to child infection is the main mode of transmission. Whereas in intermediate, it is the horizontal from one peer to another. That is the main mode of transmission. And in low prevalence, that is unsafe sexual practices. So what is horizontal transmission? Is horizontal transmission in child to child because of contaminated mineral sexual healthier workers and transfusion. And vertical, what we see in the high endemic zones is from mother to child. So vertical transmission is mother to child, common in areas, and it depends on HBV status of the mother and HBV DNA viral load. The percutaneous transmission is common in intermediate or low prevalence, unsafe injection practices, IV drug, needle prick, and household contacts. So again, sexual transmission, one important mode that is fairly common in areas of low prevalence Western countries, and transfusion. So transfusion here is one important thing. Earlier, before 1992, there was no screening of blood products mandatory. Then they made HBsAg mandatory. So when HBsAg mandate was only the mode, then they observed still the transfusion related hepatitis B was occurring. So again, they introduced core antigen also, and nowadays they're using these 2 antigens, and now the cases of transfusion related transmissions are decreasing rapidly. Nowadays we don't see much of that. So that is related transfusion.
So basically in India, the horizontal transmission is more common. And since 1992, when the screening test, specifically for the blood transfusion are made more stringent, the mode of transmission by virtue of blood transfusion has decreased. So, Dr. Balsing, what are the universal precautions that you would like to take during the interventions of surgery for prevention of hepatitis B from one patient to other, or from patient to surgeon or surgeon to patient?
Basically, from 1991, these were the universal precautions which were put forth for patients suffering from HIV. And for such patients, the potentially infectious fluids like peritoneal, pericardial, synovial fluid, CSF, semen, vaginal secretion, amniotic fluid, and any fluid with blood, these are considered as infectious fluids. And for management of such fluids, we should follow the universal precautions. Now, after the incidence of HBsAg has increased, they have converted it to standard precautions, and they have mandated to use personal protective equipments like masks, gloves, face shields, gowns, and glasses. Next slide. So these are the standard precautions, 7 standard precautions which have been explained, like use of gloves, facial protections, gown, prevention of needle sticks and other injuries, respiratory hygiene and cough etiquettes, environmental cleaning. Particularly, this is for patients who are undergoing surgery, and this is like the OT should be used as last in any patient who is suffering from hepatitis B, or linen should be disposable, that we have to use. And furthermore, now they have made 3 more new additions: safe use and disposal of shafts, which are now included in the biomedical waste disposal of hospitals, management of blood and body fluid spillage, and management of blood and body fluid exposures. So the criteria have been laid down for management of this fluid to avoid cross infection to other patients.
So, after taking all these precautions at the level of blood transfusion, at the level of OT, right, the major tools of prevention at the level of community are screening of high-risk population, then screening of blood, organs, or tissue donors, and hepatitis B vaccination. So, coming to the screening of hepatitis B, Dr. Vinay, how can we screen the population for the hepatitis B? Or are we supposed to screen entire population or some subgroup of population?
Whenever you are dealing with the chronic hepatitis B and planning for its eradication or decreasing the prevalence, so all these guidelines recommends according to its prevalence and how the country is falling in the high prevalence, low prevalence, or intermediate prevalence area. So India comes as intermediate prevalence between 2 to 8% of prevalence. So all these peoples are to be screened for hepatitis B infection, and especially high risk group, those who are IV drug abusers, blood donors requiring hemodialysis, and associated co-infections like hepatitis C virus, HIV virus, pregnant women, they should be on priority for the screening.
How will you screen these patients?
Yeah, immediately we can think for the screening with the 2 tests ideally, HBs antigen method and anti-HBs antibody. And Dr. Rahul has suggested anti-HBC has been recommended for high risk groups like blood donors, hepatitis C infection, and HIV infection people. So we can have different combinations when we are interpreting these 3 tests: HBs antigen, anti-HBs antibody, and anti-HBC. So if we have a test positive of HBs antigen along with anti-HBC, so that indicates a chronic hepatitis B infection, probably in the endemic zone. If we have isolated anti-HBC positive along with anti-HBs, probably this can indicate a remote infection which has been resolved and patient has developed immunity on its own by the natural course of illness. If a patient have only isolated anti-HBC, that report has to be interpreted. Either it could be false positive, or a patient having a very low viral load that may not count for the HBs antigen to get positive. And the patient has to be followed in a close monitoring period for repeat anti-HBC testing and viral load testing. Isolated anti-HBs indicates either patient is immune by a natural infection or by post-vaccination. And if all these tests are negative, it means patient is naive and he should be subjected for vaccination to prevent the next infection. So if you want to target hepatitis B and reduce its burden, then these 2 will be the population on target for vaccination: isolated anti-HBC positive and those who are all test negative.
So to summarize, can we say that presently we are doing the screening by means of only HBsAg, but ideally it should be by HBsAg along with anti-HBc and anti-HBs. It may not be recommendable at the population level, but at high risk population, all these 3 tests should be done to further adequate screening of this population.
Yeah, absolutely.
So coming to vaccination, what are the current recommendations regarding the hepatitis B vaccination? What is the dose of this vaccine we should use, and what is the schedule that we should use? Bhushan sir.
Hepatitis B vaccination is mandatory according to government schedule as well as Indian Academy of Pediatrics schedule. It should start at birth, because if the neonate is exposed to hepatitis B infection, then chances of getting chronic hepatitis B are almost 90%. And if the age is less than 5 years and he is exposed to hepatitis B vaccine virus, then the chances of him becoming a chronic carrier are almost 25 to 30%. And in adults, it is just 5%. So that shows that hepatitis B vaccination should be started at birth. That's the need of all. So our national immunization program has started that. Now, basically, we have hepatitis B surface antigen vaccines, which are recombinant DNA type vaccines. There are basically three types of these recombinant DNA type of vaccines available since 1992. First is the conventional aluminum adjuvant based vaccine, which is derived from the yeast recombinant DNA technique, which is widely used in immunization schedule in India as well as abroad. Angelix B was the first vaccine of that kind, and we have so many Genevac B and all those available in India. Second is since aluminium causes a lot many local reactions, they came out with a novel immunostimulant that is CPG that is introduced in 2017. That novel vaccine is not yet available in India, but it's available in US. They are conducting the trial, and the advantage of that is just 2 doses are sufficient for that. And third, which is actually most sought, is mammal cell derived recombinant type of DNA vaccine. That is again under trial in USA. That will be shortly available. Advantage of that is it, along with HBS antigen, it also gives immunity against surface epitopes. So it is called as trivalent HBS type of vaccine. So that is about theory of the vaccines. But in India now, vaccine which is a conventional aluminum-based vaccine, they are available in 2 formats as far as brands are concerned. Either they are standalone vaccines or they are incorporated with the pentavalent or hexavalent, so that the immunization becomes easy. So for any, the dose for children less than 18 years of age is 10 microgram, which is to be given intramuscular. And above 18 years, the dose is 20 micrograms. That is about posology. Then the flexible schedules are advocated. Actually, we are giving at birth dose and at 6 weeks and at 14 weeks. That is the ideal dose. But sometimes what happens, at birth is given as a single hepatitis B vaccine, and at 6, 10, and 14, people want to, mothers especially ask for the painless vaccine. So they are available in the form of hepatitis B plus triple antigen, that is diphtheria, pertussis, tetanus, plus Haemophilus influenzae vaccine plus IPV. So it's a painless vaccine. So in that case, you can give one shot single hepatitis B at birth along with BCG, and then you can give this combination vaccine at 6, 10, and 14 weeks. That is also allowed. So that's the schedule of hepatitis B vaccine. After that, actually in immunocompetent people, there is no need to give booster. Once you have completed the 4-dose vaccine, there is no need to give booster. Yeah. And there is no need to test for anti-HBS titer also. And even if it is less than 10 international units per liter, there is no need, because the immune memory for hepatitis B lasts forever. Only for us, the healthcare workers, we have to check our HBS titer every 5 years. And if it falls below 10, it's better we have to take one booster. But for general population, immunocompetent people, there is no need to give booster. It is a recommendation. If someone is not has not received, now everyone who is born after 2000 has received hepatitis B in India. There is no question. But if those who were born before 2000 and coming in adulthood, then at any time, if you find someone who has not received hepatitis B, you better do the antibody titers. And like sir has rightly said, if he is negative for all 3, or he is positive, he is not having anti-HBs antibodies, then he should undergo 016, that is recommended for adults. Then after 5 years,
it may not be applicable for the general population, but
population not.
at-risk population.
Select at-risk population like HIV patients, thalassemia patients who are repeatedly receiving blood transfusions, and patients on dialysis with chronic renal failure. These are the special situations where they are constantly, they have to face the risk of hepatitis B constantly, and plus their immunity is waning because they have immunodeficiency. So screen them for HBs antigen, anti-HBs antibody, and anti-HBC antibody. And if the titer is less than 10, they require repeated booster doses. Normal population doesn't require booster doses except healthcare workers
Or other high risk.
or high risk people. Sometimes now we'll discuss those who are non-responders. There are three reasons for non-responder people. Either they are
and the natural history of the patients, HBV DNA PCR, and to diagnose associated infections. So we can chart out better management for the co-infections like HCV and HIV ELISA. And once those who are diagnosed with the chronic hepatitis C, ideal guidelines, all national and international guidelines suggest screening of HCC with two modalities, either in the form of UHG abdomen along with alpha fetoprotein, which is specific tumor marker for the hepatocellular carcinoma. And those who are not falling into cirrhosis or decompensated cirrhosis, we can pick up fibrosis or necroinflammatory activity by invasive biopsy. We can target the population who are fitting into the treatment criteria.
So basically, idea is to see in which phase the patient is active. Patient has active virus or inactive virus. Patient has already developed any liver parenchymal disease or not, and then accordingly go ahead with the plan of action. So to pick up the early fibrosis or pick up the early cirrhosis, how do we go?
Yeah, as name suggests, fibroscan. One can imagine the name itself like something related to assess the fibrosis in any of the organ, specifically liver. So when it's a clear-cut indication of clean patient having elevated LFTs, having family history, high viral load, falling into either stage 2 or stage 4 of his natural history are the indications for the treatment. Just before elaborating the fibroscan, I would just like to go through this busy slide. But these are the standard tests. Some are patented serological tests, and some can be done on the routine blood investigations, and some are like imaging technique. So in the day-to-day life, we can do a ABRI test, which is the AST to platelet ratio index, AST to ALT ratio, and some imaging modalities, which have good sensitivity, specificity, either to diagnose cirrhosis or at least to rule out the fibrosis. So we can patients with more accuracy for the treatment guidelines. So fibroscan is very much new modality, which is most widely used in the current scenario, and it's a non-invasive method. It's painless, rapid, can be done bedside with portable instrument. Advantage, it's non-invasive and can assess 100 times bigger tissue as compared to the liver biopsy. And cirrhosis, its sensitivity and specificity ranges up to the tune of 90%. So its measurements range from 2.5 kilopascal to 75 kilopascal. As we go beyond the 5.5, it's designated as the normal range for the normal people. As we go beyond 5.5, the fibrosis increases, like from F2 to F3, and ultimately F4 means the cirrhosis. So this is the picture in shortly showing the how the fibroscan works. So it's a handheld instrument available with the vibrator and transducer, where the elastic shear wave allowed to traverse to the liver parenchyma, and it gets recorded. It's recorded back as per the stiffness of the liver tissue. So more the liver tissue, more we'll have a patient according to the KPA value. So that's reflected in our fibroscan.
So now we have proved that this patient has severe fibrosis or parenchymal disease or the active virus. So how will you plan your treatment for these patients?
As we have seen the natural history of the patient going from stage 1 to stage 4, like immune tolerant, immune active, inactive carrier, immune escape, we may not see all the features in single patient. So ideal guidelines or ideal agenda for the treatment should be to prevent the viral load and its consequences in the form of fibrosis, cirrhosis, and HCC. So all guidelines and all research has been proved that as per we decrease the viral load, we can see its positive effect in the natural history, and we can make the life of the patient at a good level. So selective, before going for treatment, you can see the selective indication for starting the antivirals, like the immune active phase, where the HB antigen is positive or negative, and the cutoff criteria for DNA is for HBe antigen negative is 2000, and for HBe antigen positive patient is the 20,000, along with the enzyme level up to the tune raise of 2 to 3 times. If you are not matching all these criteria, then either we should screen for patient to any additional reasons in the form of alternative medicines, any other co-infections, or see the necroinflammatory activity either in the form of invasive test, liver biopsy, or fibroscan. So these are the current options available for the chronic hepatitis B, like old age interferon therapies, and newer ones, nucleoside and nucleotide analogs, tenofovir, entecavir, and the recent molecule which has been approved is the tenofovir alfenamide. So if we look at the interferon, it's like a broad spectrum like antiviral, antiproliferative, and inflammatory effects. But for the recommendation, it is very selective people of fits into criteria, but it's a high level potency to decrease the viral load. The standard dose is around 5 million units daily or 10 million units thrice weekly for limited period of 6 months. For children, pegylated interferon is not approved, and we can give a standard interferon. If you're coming for the oral antivirals, entecavir was the first one with good resistance profile. The normal dose is 0.5 milligram per day, and for decompensated cirrhosis is 1 milligram per day. The side effect profile is slightly, we have to monitor lactic acidosis, and especially patients who have GFR less than 50 ml per minute. The newer antivirals like tenofovir, TDF, and TAF, that is tenofovir alfenamide, both are newly approved. Head-to-head comparison of both molecules, with TAF being more stable, more in acting at the selective hepatocyte level, and has less side effect profile in the form of bone mineral density and the renal toxicity.
So for how much duration will the treatment?
Yeah, this is a very practical question that we can discuss in this forum. The for duration, we have to see what indication we have started and what is the HBE antigen status of the patient. Those who are HBE antigen positive adults without cirrhosis, chronic hepatitis B, and who are seroconvert, like those who are converted from HBE antigen to anti-HBE antibody, they can discontinue with proper close follow-up, either in the form of flare-up. But ideal guidelines indicate the HBS antigen loss should be the target of the treatment rather than HBE antibody seroconversion. And other finite duration will be pregnancy, children less than 18 years of age, and acute symptom hepatitis B, like ALF patients. We can give treatment until the hepatitis B loss, and any chronic hepatitis B patient along with any malignancy requiring immunosuppressive medicines or psoriasis or ulcerative colitis requiring TNF alpha regime and cytotoxic therapy. So these are indications where we can give an antiviral therapy for finite duration. Rest of the people who are cirrhosis, decompensated cirrhosis, like all chronic hepatitis B and non-solid liver organ transplant recipient and HBS positive liver transplant recipient, they should be given for indefinite period of time.
So baseline HBE antigen positive patient, they should be given for definite duration. That means E0 project plus additional 6 months to 1 year. And baseline E antigen negative patient, they should ideally receive the lifelong treatment. And the patient who has decompensated liver disease, they should get the treatment for lifelong,
along with evaluation for liver transplant.
Yeah. And although the HbA1c seroconversion is the desirable goal, but it is not feasible practically. That's why intermediate goal is E seroconversion. So now, as we said, the hepatitis-related manifestation. Can hepatitis present with extra manifestations?
Yes, this is often the most ignored part of the hepatitis B treatment. So, what are the extrahepatic manifestations of hepatitis B? So, extrahepatic manifestations in acute phases, the most of these manifestations are because of the immune complexes. If they are getting deposited in the kidneys, the patient develops membranous glomerulonephritis. If they go into the neurological things, they develop polyneuropathy. Skin, they have purpuras and patches, vasculitis, rheumatoid-related symptoms, and the non-specific symptoms like reduced quality of life, uveitis, oral lichen planus, often membranoproliferative glomerulonephritis, and all the other things. So there are many things which are extrahepatic manifestations of hepatitis B. They have to be kept in mind, because once many times what happens is patient comes and gives non-specific symptoms, because these again the modality, most of them are because of the immune complex depositions in the various organs and connective tissues. What we are seeing here is one where the cutaneous manifestation. Second is the histology slide of a peripheral neuropathy. We can see the lymphocytic infiltrations in the peripheral nerves. Third is the renal artery aneurysm. There are micro aneurysms in the renal vasculature. That is because of the disease. So what the treatment is often the corticosteroids and nucleoside analogs. So that helps. What we can see is in the slide, nearly 90% patients respond to the nucleoside analog therapy. This has to be kept in mind along with the viral levels and stage of the disease. If the patient is having any extrahepatic manifestations, the nucleoside therapy or steroid should be started straight up.
Rahul, can you just take briefly regarding the surveillance for patients who are not on treatment? Very brief. So
yes, so the surveillance is again if they have to be annually screened for LFT, USG abdomen, and AFP, and iron load is again 2,000 to 20,000 because they have a very low risk of progression. Why to do AFP in these cases? Because many of the patients can develop to excessive lung cirrhosis. Again, one important point here I want to focus is we Asians have a very high risk of development of hepatocellular carcinoma compared to Western world or other world population. So one of the important, any Asian more than 45 years of age should be screened for HCC, that means AFP. And what is again the new kid in the block is the PUCA. PUCA is the protein because of the absence of vitamin A. Because AFP alone has limitations. What often we see is in our clinical practice, patient with cirrhosis, AFP levels elevated, USG is showing some nodules. So PUCA can help. The recommendation is you do PUCA and AFP. The sensitivity increases. AFP alone is like around 80%. PUCA alone is 70%. But if you combine these two, the sensitivity for cancer is nearly about 90%. So
you should do USG abdomen and alpha protein 6 monthly, and whenever in the of suspicion is more, take the help of
yes.
Dr. Sandeep, can you just focus on the indications of liver transplant in patient with hepatitis B?
Basically, any patient of who becomes decompensated because of hepatitis B and or acute hepatitis B patient with acute liver failure or decompensated chronic liver disease with MELD sodium score of more than 15, patient with hepatocellular carcinoma within Milan's criteria. Milan's criteria is if the entire tumor burden, if patient has a single tumor which is less than 8 centimeter or multiple tumors up to 3 and the entire volume of the tumor less than 8 centimeters, they can be considered for liver transplantation. And any patient
So, Vishal sir, can you just focus on the vertical transmission patient with hepatitis B? How can we prevent?
Yeah. So vertical transmission means transmission from pregnant mother to her neonate, and vertical transmission is very high if the mother is HBe positive, almost 70 to 90% chance that the neonate will get infected with hepatitis B virus. And if mother is HBe negative, then there is 10 to 40% chance that we will get transmission. But in any case, it is very important that all pregnant mothers should be screened for hepatitis B surface antigen. And hepatitis B, and even if you find in antenatal clinic that the mother has not received hepatitis B vaccine during pregnancy, it is safe to give hepatitis B vaccine. So you can complete the schedule of 016 in that pregnant mother, so that will give additional benefit to the child. Now there are two strategies to prevent vertical transmission. One is antiviral therapy to the mother, and second is giving immunoglobulins to the neonate. So for antiviral therapy, as Sir has appropriately discussed, that you screen the mother for HBe antigen, ALT enzymes, and HBV DNA by PCR, and those meeting standard indications like viral load more than 10⁶, and hepatitis B E antigen positive, they should be offered TDF, that is tenofovir treatment in the last trimester. That should be started in last trimester and should be continued to the mother in the 6 weeks at least post partum. Then the studies indicate that using TDF, there are now studies coming out that there is no risk of congenital malformations and there is no risk of getting hypoxia, that is reduction in Apgar's dose of the neonates or premature labor. So it is quite safe and there is significant reduction of vertical transmission by using TDF. As far as newborn is concerned, once you know that the mother is HBs antigen carrier, then you will have to immediately give passive as well as active immunization to the newborn baby within first 12 hours of life. It's very important. So give HB immunoglobulins 0.5 ml IM 1 shot And at the same time, you give HB vaccine first dose, I am to the different side. So if you give on the right thigh passive immunization, you give left thigh the active immunization on the same day, same time. And then complete the schedule of hepatitis B vaccine as well as we discussed before. And then if the baby is preterm or LBW less than 2 kg, then it is mandatory to give 4 doses so that the immunoconversion will be better in those. And in these neonates who are born to the HBS antigen positive mothers, you should test for an HBS antigen and anti-HBS titer at the age of 9 to 15 months, so that you will come to know whether they have properly seroconverted, have developed the antibodies against HBS surface antigen. If not, then you can repeat the dose as we discussed previously. And most important message, at least in India, is continue breastfeeding, because even there are very remote chances of baby getting infected through the breast milk, and breastfeeding has its tremendous advantages, especially in poor countries like us. The breastfeeding should be continued even if the mother is HBS antigen positive.
So basically, we should ensure the dual vaccination with the newborn and highly viremic mothers should receive the antivirals in the third trimester during the pregnancy.
Yes.
That is how the vertical transmission can be prevented to a great extent. If you permit, sir, can we just exclude because of short of time, HBCG in children, so that we can go to the surgical part, which is, Rahul, how will you manage the post-exposure prophylaxis?
Yes, briefly, very briefly. So it depends whether the patient and patient factors and the staff nurse factors, I mean, whoever is getting the exposure. So depends. If the staff nurses get, let us say a hypothetical scenario where the needle prick injury is happening to a staff. If she is vaccinated, if she is not vaccinated or vaccinated and sure about it, booster dose has been taken, patient is viral load is known or unknown, this depends. There are plenty of scenarios. So let us say scenario one, the nurse is not vaccinated or sure of the vaccination. She has to receive both HBIG and vaccination. She is vaccinated but partially. That means the adequate. So if the immune response is adequate, the HbA1c status is more than 10, no action because she is adequately protected. If it is less than 10, again immunoglobulin and single dose of vaccine. Vaccinated, nothing needs to be done. Vaccinated, but HbA status is not good. Again, test for anti-HbA1c titers. Antibodies, if it is more than 10, no action, less than 10, single dose of vaccine. Again, check for 1 to 2 months, and whether if it is required, can do the vaccination round. And scenario where she is vaccinated, but no response is there in her body. That means she has some faulty immunological response to the vaccine. She has to receive both HBIG and vaccine doses 2 months. So,
and emergency surgery. There is absolute contraindication for surgery for patients who present with acute liver failure, patient with acute viral hepatitis, and patient with alcoholic hepatitis. So if the patient comes for elective surgery and with these conditions, surgery should be deferred as far as possible. Now, as we all know that because in a decompensated patient, usually post-operatively liver dysfunction can occur, which is mostly mild and transient, and is secondary to all anesthetic agent. It is because of hypoxemia, hypotension, reduced portal blood flow, and impaired hepatic artery autoregulation. Hypoxemia is secondary to ascites, hepatic hydrothorax, hepatopulmonary syndrome, pulmonary hypertension. Now, just to assess the if the patient is a candidate for surgery, there are certain guidelines which have been put forth. One of the important guidelines is child class, which is basically a clinical assessment of the patient, and it includes 5 criteria like encephalopathy, ascites, serum bilirubin level, albumin level, and coagulopathy in the form of PT and INR. Based on this, patients can be divided into 3 classes. Child A is least severe liver disease, child B is moderately severe liver disease, and child C is uh, most severe liver disease. So these are the criteria which correlates with mortality as well as morbidity in the form of liver failure, encephalopathy, infection, renal failure, and intractable ascites. Now this is guideline which we follow. If patient is a child's A class, he is a good candidate for surgery. Surgery can be considered. Child's B surgery can be tolerated, but with preoperative preparation. Whereas child C patient, they are poor candidates for surgery, and surgery should be avoided as far as possible. Now, if patient has child A, not all candidates are candidates for surgery. In such patients, we calculate what we call as hepatic vein pressure gradient. If the pressure gradient is above 6, we call it as pulmonary hypertension. But hepatic vein pressure gradient more than 10 is a contraindication for any type of liver surgery. The second score is a MEL score, which combines serum bilirubin, INR, and serum creatinine. And there are other criteria like Mayo's classifications, which correlates with surgery. Any patient with MEL score of less than 9 is a candidate for up to liver resections. If it is between 9 to 10, then we have to find out serum sodium levels. If it is more than 140, surgery can be considered. If it is less than 140, then limited resection. And if it is the MEL score is more than 10, then surgery should be avoided as far as possible. Because MEL,
can you just make it brief?
yes. I'll just skip this. And for the emergency surgeries, these are identified risk factors. Like emergency surgery is a risk, biliary surgery is a risk in view of portal hypertension. Patients are usually with COPD, malnutrition, hypoalbuminemia, and with all the comorbidities like ascites, NKF, and post-op bleeding. So,
What the specific service?
yes. So these are the major predictors of risk: MEL score or serum albumin less than 2.5. CTP C is a risk. Emergency surgery, hepatic resection, cardiac surgery, biliary tract and major abdominal surgery, and ascites, which leads to abdominal wall herniation and wound dehiscence.
So, to come to conclusion, I will just give you a take-home message that chronic hepatitis B is a global healthcare problem. Mode of transmission depends upon the areas. In India, the horizontal transmission is more common. Adequate screening and vaccination of access population is the key modality for the prevention. Then screening of pregnant women, dual vaccination of newborn within 12 hours, and antivirals in the third trimester for highly viremic pregnant lady are effective measures of prevention, especially for the vertical transmission. Booster dose is required for the immunocompromised individuals and for immunocompetent individuals at high risk when the anti-HBs level is less than 10. Standard guidelines need to be followed for post-exposure prophylaxis in non-vaccinated or partially vaccinated individuals. Hepatitis B usually presents as chronic hepatitis and occasionally can present as acute hepatitis. Chronicity after acute hepatitis B depends upon the age of acquisition. Fibrosis can have significant role in diagnosing individuals with significant fibrosis in the background of otherwise normal initial evaluations, and these individuals will require antivirals when the fibrosis is significant, and it is also useful to avoid otherwise irregular biopsy. Interferon and nucleosides are available as standard of care antivirals for these patients. And and suppression of viral load is beneficial for prevention of microinflammation, fibrosis, and ultimately leading to the prevention of complications like cirrhosis, decomposition of cirrhosis, and hepatocellular carcinoma in long run. Chronic hepatitis B positive patients without liver disease should undergo surgical interventions as like other non-infected patients with additional measures of standard universal precautions. Hepatitis B positive patients with liver disease needs to be carefully selected for elective and emergency surgeries depending upon the presence of acute hepatitis or depending on the severity of underlying liver disease on the basis of male status of the liver disease in chronic infections. Thank you. I would like to thank to all panelists. We were a little out of the time. Sorry for that, the organizers.
Thank you everyone for such an informative session. Now I would like to request Dr. Anarse and Dr. Shilpa to please felicitate our panel members. Dr. Vaibhav Kanjevar. Dr. Ashok Mohite, Dr. Rahul Tale, Dr. Vinay Zawar, Dr. Dattatreya Mule,
Sandeep Bhalse, and very own Mission Deo. Now I request Dr. Mehkar sir to felicitate Dr. Anarase, Dr. Shirsat. Just wait for a minute. Dr. Mehkar sir to felicitate Dr. Anarase. Dr. Ajmera sir to felicitate Dr. Shirsat.
I have a few questions.
Can we please take the question answer round during the lunch time because we are short on time. Thank you. Now I would like to invite Dr. Vijay Dhanipale. He's a consultant urologist, andrologist, sexologist, and stem cell therapist, currently running Sahastram Hospital and Indu Clinic. He's here to deliver the lecture on surgical management of erectile dysfunction.
झालं काय तिने काय केलंय
Good afternoon, all of you, all organizing committee, MASTACON, Shirdi, Dr. Kute sir, all the members of the society, those who have organized such a beautiful conference over here. Now, today we are discussing on a very important subject. Basically, what happens routinely, urology, andrology, and sexology. These are the combined departments where routinely we always go through the urological procedures. Then in andrology, especially what part andrology covers? Andrology actually it covers male sexual dysfunction and male infertility. Usually we know that in any type of infertility, first the females get investigated. But before that, what I will tell you,
in sexual dysfunction, what's a routine practice we are observing? So many times patients are going for IVF, in vitro fertilizations, and at the moment you come across in such a situation, the husband, when we examine, not a single time he has visited the OPD, and at the end you come to know that there is a zoospermia, or sometimes there is no history of any type of contact with that partner. So in such a situations, by what way? Why history is important? Even if you can say it's just a call, it's a problem of female. First, we always she go through the investigations, sonography, then laparoscopy, then tube sufficiency there or not, and at the end they came for semen analysis. So friends, in this andrology, why I am discussing on sexual dysfunction? Due to lifestyle disorder, due to so many types of habits, day by day, the quality of semen, day by day, the erectile function is going down and semen quality also is going down. For such a cases, if suppose if you take a proper history and proper examination, definitely the male counterpart can be treated very nicely. What happens due to some taboo or something, whosoever the patient comes to nobody directly goes for the history, whether you are suffering from any personal problem, and patients also don't tell because they don't know whether the doctor will able to completely treat it or not. What are the types of dysfunctions? There are 3 types of dysfunctions in male: psychogenic, vasculogenic, neurogenic, and carpogenic. Many times what we feel, only due to some stress or due to some surrounding problem, it is causing dysfunction to that person. No. I'll tell you one thing, there is one study in which diabetes and hypertension and obesity, these are the common factors which are affecting the hormonal system of our body. If androgens are affected, what happens in such cases? The libido, see, it is a physiology, it is a phase. First is a desire, then is a libido, then after that the nitric oxide is excreted, and later on the blood flow goes towards the organ, and then the process of erection occurs. So any type of block in such type of chain occurs that causes erectile dysfunction. What are the different modalities of treatment for erectile dysfunction? First is a medical line of treatment. We have to take a proper history. After history taking, you have to judge to the point what exactly the cause is in a family problem, psychological depression, any other types of medicines are going on to the patients that also can affect the sexual function of a person. For medical lab treatment of adults, these are vasodilator drugs, these are centrally acting drugs, these are peripherally acting drugs. These are all medicines. First, we have to try it. Most important is the testosterone level in the body. Unless and until the testosterone level is normal, the testosterone is the male hormone, just it is not concerned with the sexual function, but it is concerned with all your body alertness, your memory, your body efficiency. These all factors are dependent on the testosterone hormone. By any means, if you are treated by this hormonal therapy, vasodilator therapy, we have to use some centrally acting medicines also. Next. So in centrally acting medicines, what happens? So many patients present with a premature ejaculation, and nobody knows what is the normal duration of their sexual function. Because due to some reason, people don't discuss it on it at all. What is the normal duration? Foreplay, actually it goes up to maximum, you can say 15 to 20 minutes. And after that, only your partner gets satisfied or they get an orgasm. And still, again, this is the reason why there is a clashes and why there are problems. Next. So here I'm going to present one study. I have so many centers. You might be, I'm a motivational speaker from SAM TV, so I used to do a very regular lecture on SAM TV in Marathi, Hindi, and English. I have centers in Aurangabad, Pune, Mumbai, Delhi, at so many places and working on big number of erectile dysfunction might be feeling. Whether the patients are available, they are coming to someone else or no. Next. So these patients are very commonly visited to the clinic. Next. So see the study over here. India is named world's importance capital here. How one can help the taboo surrounding the ED? What happens? Every person discusses about his heroic things. I did this, I did that, but no one discusses about their dysfunction, and this is the big problem. Next, again, see here, why it is labeled as the importance capital of the world. Next, see the figures. I'll tell you. Next, next, next. See, 53% of men are not aware of ED, while 78% of women are aware of it. See, why? Because men don't want to tell that I am dysfunctional, I am a robot, I am a very big man, I am a running man. But female knows that whether he can run, or he can stop, or he can sit down. 35% of men and 47% of women think that stress is the major catalyst of ED. 56% of men would like to discuss ED with their partners to fix their relationship. And this fourth statement is most important statement. 28% of women might consider separation of if their partner does not take any corrective measures. And this is a fact and reality. People don't see. If you go to family court, if you go to any place, if you observe it, and this is the reason. So the time has came. You have to make awareness of these things. One should not shy. One should not work. But these are gifts given by the nature. Next. So this just now I have discussed in between the treatment, erectile oral medication, vacuum devices, intracorporeal injections, PR therapies, vascular repairs, and penile implant. Next. So since 1970, this penile implant is started. The people, those who are not responding to medicine, not responding to ERP therapy, then what next? Sometimes I did what is the range of implants next? So these are the type of implants. The range is from 22 years to 75 years. And this is the only option which remains to the person if suppose his partner is about to run away or go away from this situation. Next. So what are the corrections we can do by surgery? Congenital anomalies, superficial, post-traumatic pathological, vascular, and organic. Next. Next. So when we are doing penile implant, this is a general profile we have to do it. Next. So this is a procedure which is done under spinal anesthesia. These are different kinds of implants they can use. Next. Now post-operative, this patient stays with us for 2 days and later on we discharge him, but he is not supposed to do any contacts for at least 1 month during surgical procedure. That is a very interesting one. You can see it. Next one. Next. Now this is a special case. Now I'm showing it to you. In childhood, the dog incidentally has bitten his genitals and he has amputated his penis as well as his testes. In his childhood, he didn't feel what has happened with him. When he grown up, then he has gone in depression. Now that patient came to us, either I want to die because without penis I can't live. At that time, we did a reconstructive surgery. Next, I'll show some videos to you. Next. So this is the situation. Here only small stump of penis is there and nothing is remaining. Next. So what we have decided? We have decided to do an implant after dissection. We have taken a consent. There is a very small penis. Whatsoever possible maximum we'll try to do. So hardly you can say less than 1 or 2 centimeters. Just it is touching to the body. There is no space. Nothing in this. Our plan was to operate whatsoever penis possible to take it out and then put in an implant. So like this, we have taken a circumferential incision to create a corona or glans penis in future when we operate for this. Next step. Next. So what is the step in this? So here is the condition. The buried penis we have removed step by step. There is a big fibrosis. The surgeon we have operated pediatric age group, we don't know. They have just concealed it down and 50% penis was not there. So by serial discussion on lateral aspects, ventral aspect, we have separated it at maximum possible length. We have taken out. Next. Now dorsal attachment, the suspensory ligament is the most important part. which is holding the penis. So many times we have seen penile enlargement or penile lengthening is done by release of this, but routinely one should not release maximum because the support of that penis, if it goes off after surgery, it can dangle laterally also. Next. So like this, we have achieved the maximum length. Now how to cover that length? So we have taken a skin graft from the thigh because there is no any tissue or nothing is there to cover up that area. So we have taken a single patch to cover that region, and after covering, we have got a complete length of a penis. And that fellow, now his testes are not there, but they are supplemented by the testosterone replacement therapy. Now this next, how this graph is produced, you can see how it looks like. Next. So this is the maximum length which I can see. There is now no length, not less than 1 inch. Now we have the suit up to 4 inches. Next. So this is the way which we have put in a graph, and after grafting, we have discharged the patient on third, fourth day. Catheter was created. Try to just go for next one. Yeah, you can go to the original videos. Yeah, yeah. Go to grafting. Go to 12, 13. So it's like spinal. Come back. Back. Yeah. Okay, now you just only around the videos only. Now this one, yeah. See the dressing. You have put in this. You have covered it with this all content details and all. Now take the next video. So after dressing, this is the situation. And after discharge, now he is on hormonal treatment, and now he has got the length proper sufficient for his erections, and now he's married also. And the person now was going for such type of disaster. Next one. Now, next, take the next video. See now, go on serially. No, don't go back now. Yes. Now, next procedure here I am showing you the penile implant. How is the procedure of penile implant? At penoscrotal region, we are injecting this solution 15 by 20 with a relying 5 ml and 15 ml of normal saline for dilution. As saying on the next, we have to take a incision. Next one. Yeah. Minimize that. Yeah. Now this is the penoscrotal incision. Yeah. Next one. Take next slide. Don't miss the serial. Yeah, like this way you have to open up the junction. Now go to next cell for dilatation. Okay, it's not that. This is sufficient. Go to next. I just zoom in. This is important step. Now here is the carbonatom. See, this is itself muscular sac, and you have to dissect it very carefully, and you have to cauterize through and through, because when you cut that area, you have to just keep on serially dilating till the bleeding stops. Yeah, don't go back. Go next one. Next. Yeah, like this. Near about, you can say 3 centimeters of incision we take it on the carpora. Now take the next. Don't miss the serial. Go to next. This is the dilatation of the scissor. This we have to go bluntly till tip of the glans penis, so that for the dilatation we have to dilate distally also. Take the next slide. Next one. So dilatation has to go till the tip of penis, and proximally it has to go till the pubic symphysis. Up to 10 number of dilators. Go for next. After dilatation, then we have to go for the implant. See how the penile implant looks like. This is a silicone implant, which is having length of, you can say, 20 centimeter, and it has some additional length also. In Indian penises, routinely we have to remove 1 or 2 sleeve, because see the diameter of the carpora is comparatively due to non-dilation is a collapse, and such large diameter implants are required for the patients who are coming from abroad. The penis size is also larger one. So if you remove the layer one by one, then it comes to 9 number. Go to the next slide. Because this removal is why important. This is a measure. Go to the next slide. Because for 10 minutes, your no system was working for 10 minutes. Still, I have carried on without slides and without your video. Just 2 minutes. Yeah. The other would have been panicked because they still I didn't do anything. I carried on everything. Okay, only 2 minutes. I'll take. Go for the next. So, because so many people don't know what penile implant. Sometimes they ask from where to borrow it. It is nothing to be borrowed. We have to bring it a silicon one. So we have taken the measure. We have taken additional suture at the base because this is additional part when we put on implant and taking out, it should not be behind. Take the next slide. So after suturing, how we put the implant? See, first we are inserting the distal part. This distal part, it goes to the tip till the last. There should not be difference of hardly half centimeter also because that one it may dangle. Now it has reached, we have finished that level. Take the next one. Then we have to go for the proximal end. Next one. Yeah, like this, we have to dilate proximal part also. And by this way, you have to push in the implant and automatically it goes till the pubic symphysis. Means from pubic symphysis to glans. The maximum length many times varies from 18 centimeter, 20 centimeter. We have to do accordingly. So this is the look. Take next one. Now this is another side. We have to so many times people feel that only one side implant will work or not. We have to fit the implant on opposite side also. So again, same direction. Go to next one. Go to next. Yeah, show the final picture. That one. Yeah. So this is the final look after surgery. The leg which is achieved, the angulation, as well as all type of deviations. Now with this patient is discharged on third day. Patient is asked not to now see post-op after you can say 1 or 2 months. Take next video. And after 1 month he can start doing his activity, bowel information. See, this is the look after 2 months. You will not imagine, you will not understand there is an implant, any scar or anything is there. And by such way his erectile function is continued. Later on, the divorce which was supposed to happen with him, it has stopped. Now he is having child and he is living happily. So this is the reason why we have planned this surgery, penile implant, and how we saved it. Okay, just stop it and go for the last slide, complete last one. That top. So just see one small video. No, that video, last one. Just a small video. It's like you might have seen all people. Do the audio. Audio here, audio close to volume button. After this, my talk is finished. This is just a speech why I'm telling you why you should be healthy, why you should be strong. After health, what you have to do? All are healthy. What next? Now, rather than disease, you are affected by your pressures, your tensions. You are getting addicted. You are smoking. You are drinking. You are alcohol. You are firing your testes. You are firing your ovaries, and at the end, leave the diseases apart. Now you are getting the lifestyle disorders, and this is taking it to such a level that you are entering a very bad dysfunction. On every Friday, you can watch me on Sam TV. Sukhi Jonathan Mantra is my show on YouTube. You type Vijay Hifale also. Audio bada maska. Hey, so you can see the shows. If you type video there, you can see my all in Marathi, Hindi, and English, and routinely all type of essential pre-shot therapy, implants, that all we are doing regularly. ठीक है, आता होगा तो देखो ठीक है. Okay, thank you very much for patience listening. Guys, it is not giving any voice. That itself is a motivation. So thank you, sir.
We are sorry about the time constraint, sir. Thank you for this informative lecture. Now, I would like to invite Dr. Vijay Sathav, MBBS MD Path from BGMC Pune, 25 years of practice as PCMC Dr. Sathav's lab, at present President IMA PCB, Professor and PG Guide at GY Patil Medical College. He is here to talk about the medical legal aspects of lab reports.
Very good afternoon. I know all of us are waiting for a delicious lunch. First of all, I thank Dr. Pude sir for arranging this CAB. And my best wishes from IMA PCB for his tenure of as IMA President Maharashtra. I'll not take much more time. Most important topic is many of our faculties, the medical legal aspects, just like your helmet, when the importance comes after the accident. So the medical legal aspect is very important about the pathology laboratory reports. On onset, the pre-analytical errors can be avoided from clinician's point of view because sample collection, this is just a brief percentage of different types of errors, coagulation, proper collection of the sample, inadequate samples. So this has to be meticulously followed nowadays because this pre-analytical errors, for example, a patient of a dengue having a minor clot in the CBC pulse, the platelet will drop down in an abnormal way, 30,000, 40,000. And I know only 5 or 10% of the labs will check for the clot when there is a low platelet count. So a minor mistake in the pre-analytical errors can be well overlooked by the pathologist. So what are the medical legal importance? Collection, selection of the appropriate laboratory. The laboratory should have the standards. I know it's difficult to have an NABL accredited laboratory at all the places, at taluka places, but at least they should have a QC programs, external quality control programs, then internal quality control programs, and that should have a proper record of that laboratory. That many of the doctors, they are not aware about the TAT, turnaround time of different tests. There are 2 TATs, TAT for the routine test and TAT for the critical test. It's mandatory for the lab to have a proper record on paper, and that should be produced to the concerned physician or a surgeon if required. Another thing is, most of the time the patient comes with the report without hard copy. They might show you on a WhatsApp, or they can use the other modalities for presentation. It's at one time it's important because we can immediately forward this report to the patients. That depends upon the type of software which the lab is using. Action taken after the report is also very important, and the information about the report, their value, how critical it is, should be explained briefly to the relatives. Many times that step is omitted by the clinicians to avoid a time factor, which can lead to a major problem afterwards. And the record, all the reports should be recorded in your case papers at the same time. I'll just brief you the different things which are present on the lab reports. Not only the name of the patient, registration number. The last one is very important, where the sample is collected on the OPD basis or IPD basis. Many times it is not mentioned in the report. That can give a problem for the collection of the samples. Similarly, time of collection of the sample, date and time of registration, collection, report, and the print time. Because again, the relatives can play a very important role, that They can claim that we had sent the sample earlier, but the reports were delayed and other things. Before 1980, we used to enjoy test matches. Up till 2010, we used to enjoy one-day matches. And now we are with 2020. That too, we see only highlights. So the time factor is very important in all these reports. If you come to the footnote of the reports, now electronic signatures are accepted by the gazettes. Who had printed the report should be on the report. The report should have a QR code to check the authenticity of the report. During COVID time, many of the laboratories, they have given a fake report of the patients for traveling or for any operative procedures. So it is always better for you people to have a QR code. Secondly, who has checked the report, who had verified the report, all these details should be there on the report. If they are not there on the report referring laboratory, you should insist them for the high-end softwares, because these all minor things are going to protect you in different MLC cases. So as I have quoted earlier, Indian Evidence Act, all of us should have a superficial knowledge of this act, that is IEA. Amendment of IEA regarding electronic record, electronic signatures and electronic agreements and consent forms are accepted authentically by the court. And this section was added in 2009, that is 81A, 81ABC, by which this record is taken as a genuine. Of course, it should have the signature of an authentic pathologist. That is very much important. So, in such cases, the burden of proof, we don't have to prove that we are right. Only the patient has to disprove it by the other ways, which is practically not possible. For example, Shraddha Bhavekar case, now we are having the different burning issue, where the police has taken the statement that after murdered Shraddha, but it is a responsibility now of a government to find out the different body parts, to do a genotyping, karyotyping, and labeling or confirmation of Shraddha's body parts. So this is how, if your reports are perfectly okay from all aspects, then nothing to worry. It is taken as a genuine proof in the law. There are only two cases. Patient was diagnosed with a DVT as usual 6 months back. He was on warfarin. He had complained of hematuria for a year. What he was admitted. As usual, the sample was taken. Now here the time plays an important role, like 2020. 8 a.m. report was ready by 10 a.m. All the NABL accredited laboratories have to maintain a critical report register, which has all the details that the critical report was informed to concerned hospital, the name of the staff, time by whom it is informed, all the things are registered. Unfortunately, this message was not conveyed to the consultant, and actually that patient has taken the same day warfarin, and unfortunately the patient landed with the complications of this cerebrovascular accident. Now, this is a pure case of negligence. That's why we have to be very vigilant about the timings which are there on the report. Case number 2. Doctor's wife was a general practitioner. working at one of the hospitals. His wife was detected as HIV positive on a routine screening, that is a tridot, which is used at site laboratories. Sample was sent for the confirmation by Western blot, which turned out to be positive. Now, doctors and his wife has a conflict, and due to this conflict, his wife has fabricated a good story that my husband, being known to the doctor, managed to get the HIV positive sample, and while giving the ferritin for a low HB, he managed to infuse that HIV positive sample. So this is just a fabricated story. But so we have to be very vigilant. Again, we have to go for the serial hearings of this case. But fortunately, the doctor pathologist was fortunate, so it was not proved. I'd like to highlight something about cyto and histopathology. Now, I'm practicing in a PCMC, and we are having a big unit of Tata Motors where they practice routinely. If I report any case of positive sample, suppose a buccal mucosa or a endoscopic biopsy positive or malignant, they invariably take a second opinion, unbiased opinion from the other pathologist before going for the major surgery. I think that is the best protocol which should be followed by everywhere. So the proper history should be provided. Many times we get slides of FNAC from the breast. The sister is confused. She tries to label after half an hour when the patient is not in front of her. Then she just judges right breast, left breast. So we document it that which is written by the sister. And if the surgeon doesn't confirm it, right or left breast, it can create a great problem. So such details, again, this is also important than the buccal biopsy. Most important thing, the confidentiality. Again, it has to be maintained at each and every step. The patient can go for the medical help if you are not maintaining the confidentiality of the report. So the take-home message is selection of the proper laboratory with the pathologist. Unfortunately, 50% of the only go for a standardized laboratory. Primary knowledge of the lab as well as the knowledge of the software is very important. Regular dialogue with the pathologist regarding that case is very important before dispatching the final report. Critical alerts, you should maintain the critical alert records in your hospitals with all the detailed columns, and you should sign it daily so that you will not miss any critical alerts from your hospitals. Turnaround time is also very important, and preservation of all laboratory reports in a soft copy manner is also very important. It should be at least preserved for 5 years. And in suppose it is a case of malignancy or something like that, we have to preserve it for more than 5 years to 10 years. So these are the different aspects. So thank you so much once again. Organizing team, Dr. Sukesh sir, and all the delegates for patient listening. Thank you so much.
Thank you, sir. Now I would request Dr. Bhule to please felicitate Dr. Vijay Sadhu. Now I would like to request Dr. Dilip Kamath to please felicitate Dr. Vijay Dahipale. Now we'll have a 15-minute lunch break. I would request you all to please gather here.
खराब होईल सर, खराब होईल खराब. कनेक्शनचा प्रॉब्लेम आहे की लॅपटॉपचा प्रॉब्लेम? एक काम करा, स्लाइड फोकस करून कसं दिसतंय काय नाही करून. याच्यात कॉपी केली का? हा, याच्यात कॉपी ठेवली ना माझ्या डेस्कटॉप मध्ये. हे होतं मेन वर स्क्रीन सेव्हर वर होतं ते. मगाशी तुम्ही दाखवलं होतं ना काही नाही, ते नाही मास्टरकॉन त्या लॅपटॉपवर. मग इच्छा आहे माझ्या पेन ड्राईव्ह. पिपीटी देऊ का काहीतरी दिसत नाही. माणूस काल माझं पहिलं चालू केले. काय Read. Read. Realize the message.
Hello, welcome everyone. We are going to start post-lunch session now. Our first lecturer is Dr. Supit. He is from Nasik. He is a physician. He is more inclined to management of diabetes. He has also done MD and DNB both degree holder, and he is practicing at Nasik. The special thing to tell about him is he has treated Mr. Amitabh Bachchan's father, Harivansh Rai Bachchan. He has received a special Gupte Award at Nasik for his tremendous work in diabetes. Over to you, sir.
First of all, I thank organizers for inviting me. I especially thank Dr. Putte sir, Dr. Mundara sir, Dr. Vadivale sir, and all the organizers and scientific committee persons for inviting me for this topic. I am going to talk on oral semaglutide. I hope after the discussion, every audience in this hall at the end will say, yeah, right choice, baby. Aha. Now, this is the title suggested by the company. I don't want to go ahead with it. So, I am going to discuss a hypothetical case because this molecule is costly. Nobody should think that I want everybody to prescribe it for every person in the OPD. That is not possible because this is very costly. The full dose costs 380 rupees per day. We are doctor, we can get at subsidized costs, so it may be 340 rupees, maybe something per day. But that's what I'm going to discuss. Suppose some of us may be having diabetes in due course of time. So should we use this molecule or not? So this is a hypothetical case. This is not a real patient. So he is a diabetic, hypertensive. He has all the risk factors like high cholesterol, strong family history, which is quite often neglected. And he is gaining weight. Now he is on medications and he is receiving all the medications in optimum doses. Now let us see what happens. This is his daily sugar charts, large fluctuations, sometimes 380 and sometimes 50 sugars. So his life is miserable. He thinks HbA1c is 7.3, not too very high. But why so much glycemic fluctuations? The episodes of hypos have made his life miserable. The weight gain is relentless. Patient is frustrated. Now he goes to a diabetologist. I have already said that that person may be doctor, consultant, or he may be mother and father of a doctor consultant who will be considered as VIP. Or he may be any VIP person in the society who is well convinced and who is affordable. Now suppose somebody, let us consider a hypothetical case, somebody meets with an accident of his bike and goes to a diabetologist, mechanic. And what that person will offer? Shall I repair your clutch, gear, brake, fuel tank, headlamp, seat, handle? Or everything is important? The same thing in case of diabetes, everything is important. You just don't have to control the fasting and postprandial sugars, but you have to see that all the sugars throughout the month, throughout the year are normal. This is called as time in range. Okay, that is okay. What about HbA1c? Because we don't measure sugar during night. So the HbA1c is one of the markers. After that, the question remains whether that person's weight is controlled or not. After that, whether blood pressure is controlled, whether cholesterol is controlled. Then the next question comes, whether you are protecting all the organs or not, like retina, nerves, vessels, his heart, brain, kidney, liver, skin. Then his ejaculatory system, then his urinary system, his defecation system, his gastric emptyme. Are you considering all these things or you just want to control fasting and BP sugars? No, it cannot be like that. Okay. Now let us have some different perspective in this matter. Any affordable person would like to have the best medicine available on this earth. Even some people don't take it, that is a different story. But like the best medicine available for diabetes are GLP receptor agonists and they are injectable. They are very costly. 5,324 rupees a MRP for one injection of liraglutide. And if you take 3 injections, it costs almost 16,000 a month. But some of us or most of us can definitely afford it. But will you prefer if it is costly? Let us see what happens. Now, when it comes to the brand, we always want best of the watches. We want best of the phone. We want best of the jewelries. Sorry, only focus on the jewelry. We want best of the car. Forget that, even we want best of the shoes. Then why to deal with your life with the petty things? Many times some consultant, very well-to-do people, they are on tablet that cost 1 rupees. इसका life इतना सस्ता है क्या? They are on glipizide, glipizide. I don't understand. That person comes to you with the car of 35 lakhs and you are treating him with tablet that cost 1 or 2 rupees. Because it will not look good if you offer an inappropriate solution to an affordable person, right? So everybody knows that the GLP receptor agonists like liraglutide are very good, but everybody fears injection. So now there is a revolution. So everybody wants a pill, no injections. Okay, let us see. So the quest for oral GLP receptor agonist is on, and the oral administration of peptide is challenging because of low pH, proteolytic enzymes in the stomach, the limited permeability, and leading to the limited absorption. Hence, the semaglutide is a breakthrough invention. It has got good homology with the normal human analog, and its half-life is very long, 1 week. So no peaks and troughs, no waxing and waning with the drug levels. So very good action over a period of time. Even if one dose is missed, that doesn't cause much problem. So GLP analog has to be taken orally, but it has to be absorbed. So there is a snack. That compound will enhance the local pH and will aid in the local absorption. Hence, oral semaglutide is a miraculous invention. And I don't mind if somebody calls me a brand ambassador for this molecule. Okay, is it that I personally feel this molecule is good, or is there any robust data to back the claims made by the company or made by somebody? Because we live in the world of evidence-based medicine, and the trials has to say it loudly. Now the various 10 trials, Pioneer 1 to 10 trials, has conducted with all the possible combinations and permutations. So somebody who is very good will like to take head on with anybody. So this molecule has been compared with all the leading brand readers in that segment. So this molecule has been compared with SGLT2 inhibitor, empagliflozin, the DPP4 inhibitor, sitagliptin, and GLP receptor agonist. It has been studied with a wide variety of background, like patients on insulin, patient having renal impairment, elderly, patient having hepatic impairment. What are the results? Now this looks pesticide, but I have made it very simple. Where there is a smiling face that represents semaglutide full dose. And you can see, you put it that person at any position is going to be fit. So that gives you the most HbA1c reduction, and you compare with anybody on this earth. See what to call this confidence, isn't it? You are comparing with any molecule on this earth, and you find that this molecule gives you the best results, as indicated by the smiling face. The dark blue represents 14 milligram of oral semaglutide. Okay. So they have shown HbA1c reduction up to 1.5, but if the starting HbA1c is high, the reduction is up to 2.6. You will say, what is this big deal with 2.6% HbA1c reduction? My downhill will do it. My this tablet will do it, but at the cost of hypoglycemia, weight gain, the organ protection कुछ चीज है कि नहीं? People are dying with the MI, stroke, and doctors are not immune to the complications. Even doctors are also dying. In fact, doctors are the most negligent persons on this earth. I am also one of them. So we do not take care of our health to the tune that we should take. So control of HbA1c with quality of life, no weight gain, no hypoglycemia, no complication, no fatal reactions, and good cardio. We will come to the good cardiovascular protection points later on. Okay, now is it that it just controls sugar and HbA1c, Or is there any additional good point with it? Yes, weight loss, not for aesthetic purpose, but to live long. So this weight loss, if you can see again represented by the smiling face, 14 milligram semaglutide scores all other modalities of the treatment in diabetes that offers best weight loss. There cannot be anything more miraculous or surprising than this in the field of diabetology. Oral thing giving you such good results. Okay. So weight loss is up to 5 kgs. How to take it? Simple. Early in the morning without food. Don't take anything for 30 minutes. It is very convenient. No dose adjustment required. Patient is alcoholic, liver, renal, elderly, no lafra. No dose adjustments in elderly. Low risk of hypoglycemia. Very simple. Okay. What are the safety and what are the summary points from pioneer trials? So large data. Then very minimum adverse events, mainly they are nausea and regurgitation, belching, no other adverse events, none of the life-threatening adverse events. Okay. Then it is associated with very low risk of hypoglycemia. If at all some hypoglycemia occurs, it is because of the additional drugs like sulfonylurea or insulin. And again, it is very well tolerated. So not only efficacy, see, from the rosiglitazone controversy, we all know that any diabetic molecule has to offer very good cardiac safety, otherwise it is of no use. So this molecule gives you very good cardiac safety, and cardiovascular outcome trials have shown 21% reduction in the events. Very big deal, man. Yes, sir. Very big deal. और किसी की जिंदगी बचाने के लिए हम कर ही क्या सकते हैं? We give statins. Statin has also limitations proved by Jupiter trial. We give aspirin. It also offers some protection, but not in all. Then we can use chlorthalidone, but not in all. SGLT2 inhibitor also offers some protection, but this offers additional protection. You are preventing cardiac. You are preventing myocardial infarctions. You are preventing strokes. Again, adverse cardiac events, they are all less with it. Major adverse cardiovascular events. All cause mortality is also less. CV safety 49%, 51%. Mind me, these are very big figures. किसी का जोखिम आप 50% कम कर रहे हो with one medicine. Can there anything be better than this? Because lifestyle modification, I again re-emphasize, it is the best thing. But how often we do it? How religiously we do follow the lifestyle modification? Isn't it the truth that most of us have taken gulab jamuns today? Yes. Then how can what lifestyle modification we are talking of? So why not to take good medicines if you have diabetes? It is sure that tablet is working, isn't it? Okay. Is it that the only myocardial infarct is prevented or also the stroke is prevented? I think if somebody is given a chance, boss तेरे को कुछ तो मिलने ही वाला है, या तो तेरे को अटैक मिलेगा नहीं तो stroke, बता क्या? Nobody will prefer stroke. So stroke should also be prevented. This is the drug that prevents it. And see the 32% reduction. Absolutely stunning figures. Okay. Now let us see what are the ideal patients. The same thing that we have discussed. First line, metformin. After that, we can go for this. But even we can go for without metformin also. But this I am talking off-label. Why off-label? Because injection semaglutide has been advocated in the reduction of obesity where there is no high HbA1c. So when there is high HbA1c, why not to use it as the first drug? Who has prevented you? Isn't it? So sometimes evidences are funny. Okay, but we can understand what it wants to say, isn't it? Then it is superior over all other drugs to compare to control the weight. Very important. Then low risk of hypo was this is the hypo. Otherwise, person from Nashik will go to Mumbai in 1 hour, but there is a chance of accident. So we want to reach to Mumbai within shortest period without accident. That accident is hypoglycemia. Okay, so this is the drug that gives you fast entry to Mumbai without any accident. Okay, then adherence is an issue because it is costly. So we must be careful about giving it to anybody. ये 350 रुपए की गोली कोई लेने वाला है क्या? Some people they develop nausea, regurgitation, vomiting, and they fear कि तुमने क्या दे दिया डॉक्टर को बहुत तकलीफ हो रही है. So you have to educate the people. So adherence becomes an issue. Then the risk. Some people are very high risk, especially the hereditary risk is always neglected, but that is an equally important risk. So if that person has some risk in the form of smoking, VAT, either one episode of angina or some IST, PTC, stroke, whatever it is, then this becomes the drug of choice, no compromise. So no dose adjustment in hepatic, renal, or whether patient is elderly, बिंदास देने के. Okay. So now that same person again, he had very huge fluctuations. Now what we did, we removed his glimepiride, we removed his sitagliptin, and we added ribelsus, semaglutide, oral. Starting from 3, then going to 7, then going to 14 after a period of 1 month, because there is an issue of tolerance. Not all people tolerate it well. Maybe 20-30% they develop nausea, vomiting, but it goes over a period of time. And many people they accept it, and some belching mild, some mild irritation, they remain for quite few months. But when patient sees his HbA1c is coming down, no sugar fluctuations, weight loss, good satisfaction, then you will say, "Itna belching chalega." Okay. So now see his sugar profile, almost like a normal person. Okay. Now again summary. It has shown good HbA reduction up to 1.5, good weight loss up to 5 kg. When HbA1c is high, there is very good HbA1c reduction. Then it is good as compared to all other drugs and in all other backgrounds in HbA1c reduction. And it has got very good safety, cardiovascular safety, stroke safety as compared to all other drugs. It is established in all the backgrounds, renal, hepatic, elderly. Okay. So this is the feeling after oral semaglutide treatment. That's all I wanted to say. Thank you. I will be happy if there are any questions. Dose of semaglutide start from 3 mg, then go to 7 mg, then go to 14 mg, and keep a period of 1 month for observation. Because not necessarily patient will be only on this drug, patient may be on some small dose of sulfonylurea, maybe basal insulin. So you also want to see whether other drugs are causing hypo or not. Tolerance issue is there, nausea, vomiting, regurgitation, bloating. So if that is not there, patient is tolerating well, then from 3 to 7, then 7 to 14. Cost is same, almost only a difference of 30-40 rupees. The cost of 14 rupees, printed price is 380. I think we get 20% discount, calculate.
The first line of treatment you can use this.
I have given it.
Instead of using other anti-diabetic treatment.
First of all, metformin must be given because that addresses the primary defect in diabetes. But suppose some patients do not tolerate metformin. That is an issue sometimes. But otherwise, metformin must be there. And then we can go for this.
This one to be used. The other drugs have to stop slowly.
Yeah, because I have taken out glimepiride that was causing hypo. Now, sitagliptin, ribelsus is already the much advanced formulation of sitagliptin because this was DPP4 inhibitor and we are giving directly GLP analog. So already we are giving the original stuff to the patient, which is much more efficacious. So DPP4 is out. Glimepiride should ideally be used least in case of doctors and well-to-do people. Because when we have other so much good modalities for the treatment, why to use this glimepiride? Glimepiride is a बंदूक, साले काम करना तो तेरे को खत्म करूंगा। पैंक्रियास को जाके वो बीटा सेल को ऐसे बंदूक लगाता है। अब बंदूक लगाने से तो कोई भी काम करेगा। त्यात मजा नाही ना। तो म्हणून सतत ते पेशा आधीच त्यांचे apoptosis चालू आहे, आधीच बीटा सेल फेल्युअर झाले, तो उसको का बंदूक लगा के काम करवाना है?
Thank you, sir.
Yeah.
For this informative talk. Our next speaker for today is Dr. Vivek Kasper from Thane. Scholar at EASD 2020. He has been speaker for various national and international conferences. He has published many publications in national and international journals, and he's having more than 600 patients on oral semaglutide, the same molecule.
It was a very good lecture, talk from Supresa, and sir presented some demo case. I'll present. For me, it's not very difficult to convince the patient in my area because Thane is people of IT people and they have a lot of income. So it's a matter of just to convince the patient about the side effects regarding this, that what adverse events like nausea, vomiting you will be having, and how to manage all those things. So I'll start with my first case. This case is of a doctor only. This doctor came from Solapur to treat diabetes. He was taking uncontrolled type 2 diabetes, multiple ODs and insulin. And his age was 36 years, and current medications was he's taking metformin 1000 milligram, glimepiride 2 milligram, pioglitazone 50 milligram, and insulin mixed-start 30 and 20 units twice a day, and also was taking antihypertensive. He was moderately active, since he was a doctor, so he was very much concerned about the HbA1c. He was hypertensive, dyslipidemia, obesity, and he had developed a retinopathy. And due to a lot of insulin mixed-start and lot of hypos, intermittent hypos, he had a gain weight of 66 kgs in 7 years. The BMI is around 33.5 and HbA1c is very high, 1.8, despite taking insulin. So now in this case, there is a challenge. If you go to Sustain 6 trial, which is a trial of that is Ozempic, that is once a week semaglutide for diabetes, and if you also go for leader trial, there is one cautious statement that is giving the GLP-1 receptor agonist that increases the chances of the retinopathy, worsening of retinopathy. So we took that risk. I told him that if you give this drug, there will be chances of worsening of retinopathy. So we have to carefully monitor your retina. You have to do routine screening for the retina also. So he was on mixed-start and worrying about weight gain, and he was not understanding that my sugar levels are fluctuating a lot. It's hypo and hyper, and still HbA1c is 11.8. Despite taking insulin, and definitely he was having retinopathy. If there is retinopathy, there is nephropathy also. So despite knowing this risk of worsening retinopathy, we initiated oral semaglutide and keep close watch on frequent retinal examination. And currently the patient is taking semaglutide 14 milligram. After 3 months of therapy, he lost 16.7 kgs of weight with improved vision, more energetic, and HbA1c reached the target. So how was the course of the treatment? The baseline HbA1c is 11.8. At first follow-up, his HbA1c reduced to 8.1. At second follow-up, 7.8, and third 6.8. The weight was 91, which came down to 77.4. The BMI reduced to 33 to 28, and the sugar levels are awesome here. So we stopped glimepiride, we stopped insulin, and we kept only empagliflozin 12.5 and metformin 500 twice a day, and oral. Just added oral semaglutide 3, 7, and 14 as a course of 1 month. And HbA1c reduced to 6.8. So after 4 months of therapy, the fasting, which was 195, reduced to 90. The PP reduced to 146. HbA1c, almost 5% drop in HbA1c. And weight, 16.7 kg of weight loss, and reversal of retinopathy. So the retinopathy was gone from the patient's retina. The BMI also lost very good 33.5, and the patient is presently taking oral semaglutide 14 milligram. And since the patient was doctor, he was affordable, so he is taking this treatment. So he was on multiple ODs, insulin uncontrolled, and with 3 months of therapy of oral semaglutide helped to achieve him glycemic weight loss, without increasing the risk of diabetic retinopathy. That was the biggest challenge. And we were tense about it, that all the trials have shown sustained 6-year trick. I think this is the worsening retinopathy. So we come to the second case. This is the newly diagnosed type 2 diabetes patient with ischemic heart disease. The patient suffered with ischemic heart disease, and while admission, he got diagnosed with diabetes. So he visits the clinic with following routine tests: no lifestyle, and he has a grade 2 obesity, age of 52, diabetes newly diagnosed, but he was diagnosed when he was admitted for acute ischemic disease, that he got a MI. At that point of he got diagnosed with diabetes. So he had obesity, weight of 116 kgs. At admission, the HbA1c was more than 15%. His serum creatinine was 2, and 2D echo, the ejection fraction was 35% only. At initial stage, the patient was admitted due to high-grade fever and severe septicemia and MI also. The blood sugar went up to 600 milligram twice daily. During hospital stay, patient was diagnosed with IHD based on ECG recording. And after initial recovery of leukocyte count from 35,000 to 16,000, patient took DAMA. He was not treated at hospital from my side. He took DAMA. And at time of discharge, patient was taking regular insulin with uncontrolled plasma glucose levels. So after that, he came to my clinic after taking DAMA. And at the diagnosis, HbA1c was more than 15%. And serum creatinine of 2, and injection fraction of 35%. And we started him on dapagliflozin based upon eGFR, and metformin 1 gram per daily. Again, depending upon eGFR, we can give dapa and metformin 1 gram if the eGFR is more than 30, and started on basal insulin. We brought that HbA1c to 8.3 with basal insulin, and then his creatinine improved, and then we started on oral semaglutide. Insulin was stopped, and all DAPA and semaglutide 3, 7, and 14 were continued. At the end of, you can see the HbA1c is 6.3, and the weight was 101, and the creat was 1.2. Then the ejection fraction improved from 35 to 55%. So after 4 months of treatment, the HbA1c reduced to 6.3, and the weight was reduced to almost 17 kg weight loss. The creat improved, and the ejection fraction was also improved. And this might be because of dapagliflozin also, depending on DAPA heart failure trial also, and definitely Pioneer 6 trials, where it is gives a cardiac superiority. And he's now presently maintained on, obviously maintained on all the other antihypertensives and anti-cholesterol, all the aspirins, and he also is taking Vimada also for the ejection fraction. And therapy of oral semaglutide continued to achieve glycemic targets and weight target, and presently on update the weight is around 98 kg with increase in ejection fraction also. So the third case is the case of remission of diabetes, obese diabetic patients. So newly diagnosed, no, I thought it's not newly diagnosed. This is the original chart that I'm showing you. You can see the HbA1c is around. HbA1c diagnosis was 7.5, and after 3 months or 4 months of therapy, the HbA1c dropped down to 4.9, and the weight was around 100 kgs. The patient was taking glimepiride, metformin, pioglitazone 15, and thyroxine supplement. The HbA1c at baseline was 7.5, eGFR 42. Then the patient, due to very heavy weight, had obesity, knee joint pain, hypertension, and hypothyroidism, and obstructive sleep apnea also. She was diagnosed with diabetes 3 years back, and a known case of hypothyroidism, taking 25 mcg of thyroxine. Complaint severe bilateral knee joint pain, difficulty in walking, exercise, patient in dull lethargic mode. Post treatment with oral semaglutide, the patient is off medicines also. The patient is also off medicine of thyroid medicine also. So the presently patient is taking no medicine because of good amount of weight loss. Patient lost from 100 to 81 with HbA1c 7.5 to 4.9. Now the patient is off even oral semaglutide. She gained slightly post 2 kgs. Now present the weight is 83, but presently she is taking no medications and she is well controlled on diet and lifestyle. So 19 kg of weight loss, fasting reduced by 134 to 101, HbA1c 7.5 to 4.9, and antihypertensive it was stopped. So that was summary. And the last one is that a case of uncontrolled type 2 diabetes with ischemic heart disease post CABG. Again, the real case, the HbA1c is around 8.1, and which came down to 6.8 after 7 months of therapy. She's a long-term patient. She was a patient of mine before launching of oral semaglutide. So the patient is currently taking basal insulin with metformin and ILG post CABG. HbA1c was 10.1. Ejection fraction was 35%. So we initiated oral semaglutide on basal insulin, and slowly HbA1c reduced from 10.1 to 6.8, and weight was reduced to not much, 73. So if a BMI is around slightly on 27-30, the patient doesn't experience weight loss, that amount of weight loss. If a patient has a very high weight, I mean above 100 kgs or BMI is around more than 35-40, these patients have a good amount of weight loss. That is, higher the baseline weight, more is the weight loss. Here, higher baseline weight is not that much. So BMI is around 27. So these patients don't experience that much of amount of weight loss. Only just 3 to 5 kgs is sufficient enough. So after treatment, the weight reduced by 3.2 kgs, and sugar levels random, post-prandial from 305 to 109, HbA1c from 10.1 to 6.8, and ejection fraction from 35 to 45%. That is 10% of improvement. The patient's age is more than 17 years with long-standing diabetes. BOM was normal, but HbA1c was raised and patient was operated for CABG. With oral semaglutide, HbA1c was corrected, improvement in ejection fraction was observed, and the patient is taking oral semaglutide plus basal insulin in geriatric population without doubt medication, well tolerated, and it can be used for considering secondary prevention of CV disease. So thank you for any questions.
Why this semaglutide you are in the sequence of 3 milligram, 7 milligram?
It's because of tolerability. If you have a very severe obese patient, we can start with 7 milligram directly. So just few days back, a patient weighing around 150 kgs, I started straight away with 7 milligram.
What is the duration of 3 to 16 from 3 to 7 and 7 to 4?
See, according to the company, they usually say 3 milligram for 1 month, then 7 milligram for 1 month, then 14 milligram for another month, from third month. But you can innovate from your side also. I have done 3 milligram 10 days, patient tolerated well. I shifted him to 3 to 7 within 10 days, and within 20 days I shifted him to 14 also. So it depends upon your own clinical experience, evidences, the patient tolerability, all those things can take into consideration. Now, not necessarily you should say what the company says. I have done many things, innovative things. Sometimes after the patient is taking 3 milligram, the moment I switch patient from 3 to 7, band bacha tha uska. He starts vomiting like anything. Not tolerable. So in this, what some doctors what they do, they follow some normal mechanism. They shift to 3 milligram. What I do is that I don't shift to total 3 milligram. I give him 3 milligram for 3 days, and then 7 milligram on 4 days. 3 milligram for 3 days and 7 milligram on 4 days. Slowly, I reduce the duration of 3 milligram, and the moment the patient starts tolerating 7 milligram, I stop 3 milligram. So it's your own, way of treating. Nothing like just what the what guidelines say. It's your own confidence on this molecule. I have developed a lot of confidence because initially 600 patients, it was all like it's a khelna, it's a child's play for me now.
There is no diabetes, but there is obesity. Is this semaglutide useful?
Off label, I can't talk that because of off label. You can use off label, but again, I have tried it, but it's not recommended. You should advise patient it is off label. Some patients, see their relatives having diabetes and they're saying, sir, ये मुझे भी दे सकते हैं क्या? वो diabetes नहीं है. मतलब दे सकता हूँ मैं, लेकिन off label है, कुछ हुआ मैं responsible नहीं. But they are launching this drug in form of injection with a brand name of Wegovy in 2024, which is much better than oral semaglutide. So it's better to wait for by 2024. It's a brand name is Wegovy. Pardon? the moment it was launched in India. It was launched in India on 17 Jan. So from day one, I started using it. Yeah. So many patients I have used, I shifted patients from Victoza. Those patients were on Victoza to oral semaglutide also. So even before the launch of oral semaglutide, many patients were on Victoza also. So I told them that just wait for 6 months, your injection will be going to stop now. So I shifted many patients from Victoza to oral semaglutide. If you know the dose of Victoza, it's 1.2, then you can shift from 1.2 to direct 7 milligram. 1.2 of Victoza, that is liraglutide, is equivalent to 7 milligram of oral semaglutide, and 1.8 of Victoza is equivalent to 14 milligram of semaglutide. So it depends on how I started promoting this drug to my patients even before 6 months of launching only. So I got a lot of response in these patients, and the word of mouth spread like like abhi wo kaun sa movie hai Kantara. So word of mouth movie hai wo. So the patient used to come, I want to start this drug. And since I said I practice in clean society, so I get a lot of patients in terms, and they don't have financial issues.
Thanks, sir, for the informative talk.
Thank you.
Now I request Dr. Garud, sir, to felicitate Dr. Suppe, sir. Dr. Raskar, sir. Dr. Garud, sir. Thank you, sir.
Sir. Thank you. Yeah.
Next, we are going to next, we are going to have a lecture from our Dr. Saurabh Deshpande from Sriram, who is presently working in Mumbai. He is a cardiac electrophysiologist, and that lecture will be online. So please be seated. Once we get connection, we'll start the lecture. I'll take pleasure to introduce Dr. Saurabh Deshpande. He has done MBBS from Nair in 2009. He has done MD from Sion Hospital, Mumbai. He has done DM from GMC Trivandrum, and he has after that done PG fellowship from Sri Jaydev Institute of Cardiovascular Sciences, Bangalore. Presently, he is attached to Jaslok Hospital, Nanavati Hospital, JJ Hospital, Jagjivanram Hospital, Global Hospital, Fortis and Apollo Hospital in Mumbai. He is actively doing electrophysiological interventions there. He has received many awards. He has written chapter in Merit's textbook of electrophysiology, which is published from New York. We are really proud to have Saurabh Deshpande today in this conference to talk, give his talk.
Hello.
Yeah, this is the.
Am I audible?
Yes.
Good afternoon, everyone. Thank you for the kind words, Dr. Dev, sir. Hello. Hello. Shall I start? Good afternoon, everyone. Thank you so much for those kind words, Dr. Dev. I'll just start with my topic. So we'll try to cover what sudden cardiac arrest means, why bother about it, what is it exactly? Is it same as heart attack, or is it different, or what is it? We'll come to know after this talk. What are the types of rhythms that we encounter when you have sudden cardiac arrest, and what we can do, which is the most important part of sudden cardiac arrest. So essentially, sudden cardiac arrest means sudden stoppage of heart function leading to acute shortage of oxygen to the whole body. So if you have to put it in the layman's term, this is what it is. But what exactly happens is the heart either suddenly stops. As you can see in this diagram, there is no beat whatsoever after one QRS. So this is what is called as asystole, or you have a rhythm which is going on like this. So this is a normal rhythm, and then there is a chaotic rhythm going on after that, which is called as ventricular arrhythmia or ventricular fibrillation, which leads to sudden cardiac arrest. This is a famous picture. This has recently happened about a year or two back. He is Christian Eriksen. He had collapsed on the football field, and this is how the his teammates and his crew covered to avoid the whole show for the crowd. It was telecasted in international television. So sudden cardiac arrest has taken center stage more or less around that time because it has suddenly picked up importance. All in all, the record of sudden cardiac arrest all over the world is not very good, especially in India. In India, the last study was done in 2012, and it said that sudden cardiac arrest may comprise of 10% of total mortality. It has been increasing. We have used to have less coronary artery disease earlier, but we are not now having more coronary artery disease. So we have a variety of cases which are presenting with sudden cardiac arrest, and many of them had coronary artery disease. The incidence, if you say, it is around 53 per lakh population worldwide. This is the recent study from Europe, which is showing the incidence of around 38 per lakh molecules. These are few news items which you all might have read, heard, and that is why we have to know what sudden cardiac arrest is. Is it same as heart attack or not? So there are two systems that the heart has. It has its own blood supply, which is called as coronary blood supply. There is a coronary artery on the right side and another on the left side. And what we call heart attack is the problem with either of these vessels. So if there is a block in either of these small vessels or big vessels, you can have heart attack. In contrast, if you have another system working on in the heart, which is the electrical system of the heart, it's called conduction system. So any problems related to these conduction system lead to sudden cardiac arrest. As we have seen before, it can suddenly stop, which can give rise to asystole, or it can suddenly start malfunctioning, and there is too much function going on the lower chamber, leading to ventricular arrhythmias and sudden cardiac arrest. So sudden cardiac arrest is basically an electrical problem as opposed to plumbing problem or the blockage problem in heart attack. The reason for sudden cardiac arrest most of the times is electrical malfunction. So it can either cause stoppage of the heart or it can increase the heartbeat, like ventricular tachycardia or ventricular fibrillation. As opposed, in heart attack, there is a blockage of the artery supplying blood to the heart, that is called coronary artery, and that can lead to heart attack. Most common of the precipitant is stress nowadays. It can either be physical or mental. The risk associated with sudden cardiac arrests, mostly many of these patients have had a heart attack in the past. They might have had heart failure in the past of any type. They would have had some abnormal heart rhythm, which has now progressed and it has either stopped the heart or caused some irregular rhythms in the heart, leading to ventricular arrhythmias. Or patient must be having low function of the heart, that the pumping capacity is low, which has resulted in imminent electrical problem and sudden cardiac arrest. Another important thing which we miss out most of the times is family history of sudden cardiac arrest. So if any person having a family relative who is close to them, like brother, sister, father, mother, having sudden cardiac arrest before the age of 50, then it is considered a significant risk factor for sudden cardiac arrest in that particular person. The risks of heart attack, we all know: smoking, high cholesterol, diabetes, hypertension, everything. This is all well stressed upon everywhere in the social media, so we are aware about it. If you compare the symptoms of sudden cardiac arrest versus heart attack, sudden cardiac arrest in general does not have chest pain or breathing difficulty, nausea, fatigue, which is typically seen with heart attack. It is just the person collapses in front of you. I'll be sharing one video afterwards, so you'll come to know what it means. And there is sudden collapse. This person is unconscious, not breathing, no pulse. That essentially is sudden cardiac arrest. So these are the two rhythms which the patient can have post sudden cardiac arrest. So this is the normal sinus rhythm. Why I say that is there is a PQRST, and it is going on normally at normal rate. What happens in ventricular fibrillation? The things go chaotic. It goes up, down. The heart doesn't know what is going on. Or ventricular flutter fibrillation, which are regular rhythms. So either of the three rhythms, the rate is so high that the heart is not able to pump the blood out of ventricle, and there is a resultant sudden cardiac arrest. So these rhythms, when the heart rate is high, are called as shockable rhythms, and we have to immediately shock such person if possible. And CPR might be required later on, depending on the result of the shock. There is something called as non-shockable rhythm. If the person presents to us with a rhythm like this, which is a flat line, or pulseless electrical activity. So what is meant by pulseless electrical activity is you have something going on the ECG, but when you touch the person's pulse, there is nothing felt. That is pulseless electrical activity. So these two types of rhythms are actually non-shockable, and the treatment is not shock. We have to give CPR in such patients to revive them. So this is what ventricular tachycardia means. If you consider this as your heart, the car is the heart, and the person who is driving, the person who is driving is at the ventricle in case of ventricular tachycardia, and starts driving at a very high rate, and the rate is most of the times more than 100. The person can have normal heart or can have some abnormalities in the heart. It can be detected either on echocardiogram, MRI, or PET. There are multiple imaging modalities. In contrast, talking about ventricular fibrillation, again, the driver is the same, the ventricle, but there is very rash driving going on inside the heart. So the rhythm is, as you see here, is chaotic. You don't have any sense of it. Most of the times it is irregular. There is no pulse, and again, it can have normal or abnormal heart in this situation as well. In contrast, asystole or pulseless electrical activity, as we discussed before, you either have a flat line or you have some rhythm going on, but if you check the pulse, there is no pulse, or if you have an echocardiogram and put a probe on, you won't see the heart contracting at all. So that is what is called as pulseless electrical activity. So what can we do if you encounter such a scenario? So there are some emergency numbers. There is 112, there is 102, which is the ambulance and emergency numbers, or you have 108, which is the disaster management number, which can again connect you to the ambulance, which can help you. There is something called as emergency defibrillation. If it is locally available in the building, in the area, in the area that the incidences happen, we can use that. But the most important thing that we should be equipped with is cardiopulmonary resuscitation. So what does CPR or cardiopulmonary resuscitation mean? So there are two types of cardiac arrest. It can either happen inside the hospital or can happen outside the hospital. So inside the hospital, okay, you think that there are trained people there, so they can take care of it. But our role comes as a lay bystanders in case of out of hospital cardiac arrest. Most important thing, if possible, we can prevent it, like have regular checkups, find out if you are at risk for sudden cardiac arrest, and then get it corrected before it happens. But in case that most of the times is very difficult to find out. So in case you are in a scenario where there is out of hospital cardiac arrest, immediately call the person responsible, like an ambulance or whatever emergency numbers you have, but don't wait for them to arrive at the scene. Immediately we have to start CPR as high quality as possible. Then the later part can be taken care of by the hospital itself. So what does CPR mean? If you are trained in cardiopulmonary resuscitation, you can have a CPR which comprises of both breathing as well as compression of the heart. If you are not trained, compression only CPR also helps a lot. The person can actually be rescued out of that situation and can be taken to the hospital and helped for the permanent management or long-term management of the person. So when the area has something called as AED. So what AED means is automated external defibrillator. I'll be talking about it later on. So if that is there, once it arrives, we should immediately connect it to the patient as is shown in this diagram. And then the AED itself will give the instructions to what to do later on. Now, once you have revived the patient through CPR, then that is the rest of the work is for the medical professionals to take. They generally manage the airway with endotracheal tube, manage respiratory parameters like breathing, saturation or CO2 saturation. Then they manage the hemodynamics, and we have to get a 12-lead ECG to find out if there is anything very serious about it going on and if the person needs any intervention at an early stage. If the patient is awake, good enough, then you can go ahead and do other management as we discussed before. If the patient is comatose, then we have to do other things which are more important, like temperature management. It is not very commonly done in resource poor country like India, but we can do the brain CT or EEG monitoring and rest of the critical care management as is required for an awake patient, so that we can stabilize the patient and revive as much as brain function as possible. When talking about pediatric rescue, so again the steps remain the same. You have to identify, you shout for help, call the person who you can help you. Then you can have two types of patients in a pediatric CPR. You have a child or you have an infant. Child CPR remains almost the same as we discussed before. For infant CPR, we can either use a two-finger technique at the as is shown in this diagram, or we can use a thumb encircling the hands technique. That as the person is holding the infant like this, and both the thumbs are at the place where the compression is to be given. So this is the video I was talking about. Just have a look at this. These people talking and walking inside. They have come inside the society or a building, and the person suddenly collapses. So this is what sudden cardiac arrest means. So now she is untrained, but she has shouted for help. People are coming for rescue, and there is some trained person who has arrived. Luckily, he has all the training required for CPR. He immediately finds out that person is having sudden cardiac arrest. He immediately opens. He tells other people to call ambulance for the further treatment. He takes out the AED that he has with him, but he starts doing CPR. This is the angle that should be there. It comes all in the training. Now the AED is there, automated external defibrillator. Once it arrives on the scene, the AED has two paddles. They have to be attached. It has the diagram and everything. It has to be connected to the patient. The machine itself will detect the rhythm and will give shock, as was seen in the video. So this video will give you an overview. It is very difficult to teach CPR like that. So once you have revived the person is awake, reached to the hospital, then we have to think about the long-term therapies. So it depends on what diagnosis the patient had, which led to the sudden cardiac arrest. Most important thing is history and examination, but many of the patients may require some diagnostic tests to arrive at the diagnosis for the sudden cardiac arrest, like ECG, echocardiogram, longer term monitoring of ECG like Holter loop recorder, treadmill or tilt test, blood test, or ruling out coronary artery disease with the help of coronary angiogram or some other test, whatever is available there. There are some rare causes which require implantable therapies. I'll be coming to those therapies later on. But these require specialist attention, and once if it is diagnosed, if the person is diagnosed to have any of these things, they may require treatment for prevention of sudden cardiac arrest. Now there are two types of treatments available. There is a temporary type of treatment, which is comes like a vest, and it has electrodes inside, which are inside touching the heart, touching the body, and there is a monitor here. Again, it has buttons on that, and you can just push them if something happens, and it also gives automated shocks as well if required. And then you have a permanent management in like pacemaker or the implantable cardioverter defibrillator. So this is what I mean by the wearable ones. It is actually for a temporary management. FDA approved long time back. It is used only for patients who are awaiting ICDs, or who are patients who are not a candidate for ICD. Either they have deferred, or life expectancy is low, or for whatever reason, or the people who have had heart attack in last 40 days and have very low function, and we are awaiting ICD after 40 days, then we might use wearable defibrillators. There are advantages, like it can shock if the rhythm is proper, and life can be saved, but there are certain disadvantages. The most important thing is cost in India, and availability is not very high. But other than that, patient has to wear it continuously. There is no pacing capability. There are noise issues which can lead to inappropriate shocks. So these are main things which are hindrance to use of wearable defibrillator. There have been some news reports where it has been used somewhere in Delhi at some time. Pacemaker is the device which delivers current to the heart at specified voltage. So it is required when the heart's own conduction system is not able to produce the electrical current. So it can be like two types. It can be temporary or permanent. Temporary has multiple company look. The look is different, and or it can be permanent, where the device is inside the body and two leads are connected to it. So pacemaker has two parts. It has pulse generator. It has leads. The pulse generator is something like this: that battery and electrical circuit, and the leads are connected. This tip goes inside the heart, and the other end is connected to the pacemaker. There is a new type of pacing which has come up right now since last few years, and in that we put the lead directly inside the normal conduction system to give more or less same ECG that the patient had before having this problem with electrical system of the heart. So the long-term management, long-term benefit of this therapy is very high. So many of the patients going for dual chamber pacing are opting for conduction system pacemaker nowadays. Second part of the therapy comes ICD. So before going to ICD, we should know what defibrillation means. So defibrillation is the process by which a high energy current is delivered whenever there is a rapid irregular rhythm is going on, and with the help of that high energy current, the rhythm restores to normal sinus rhythm. This is something what happens, as we saw before. You have certain type of sudden cardiac arrest where this type of chaotic rhythm is going on. There is a defibrillation shock delivered, and then normal rhythm comes back. So essentially, it stuns the heart for some time. We should always look for this rhythm, this return beats. If they are not there, we have to start CPR, as we discussed before. So ICDs are of two types. It can be external or internal. Wearable ICD we saw before. There is manual ICD or manual shocking pads that we use in most of the OTs or hospital setups. Or there are AEDs, which should be available at public spaces to avoid sudden cardiac arrest, as we saw in the video before. Or there is an internal type of defibrillators that can be inserted either through vein, which is called as transvenous implantable cardioverter defibrillator, or it can be inserted in subcutaneous plane, which is called as subcutaneous implantable cardioverter defibrillator. Here you don't have to access any vein for subcutaneous ICD. So this is how they look. This is the transvenous defibrillator. Here the machine is there, and the two leads connected, where leads are going inside the vein and then inside the heart. This is subcutaneous, which has a pulse generator in subcutaneous area. Even the lead is outside the heart, just below the sternum. ICD has again two parts. It has a device, it has a lead. The device is divided into two parts. One has the bigger part is capacitor, then there is a battery. The other things are for transmission or telemetry, and then there is a connector block where the leads are connected. These are the leads. There are two main types of leads. You have DF4 lead and DF1 lead. That requires some technical details, but I just wanted to point out there are two types of ICDs available. So it can be a single chamber ICD. As you see here, there is a one lead which is going inside in the lower chamber, and this dark part that is there, that is the coil which delivers shock inside the heart. It can be dual chamber ICD. So this is one of the leads is up in upper chamber, one of the leads is in lower chamber, and this is how the dual chamber ICD looks. Both of these ICDs have only one dark black band here. So these are called as single coil ICDs. There is something called as dual coil ICD, which has one more coil in the upper part of the heart. But this is nowadays this is not used due to multiple reasons. There is something called as CRT-D. So where in addition to defibrillation, sometimes you require the heart to contract together. Both the sides of the heart many of the times are not contracting at the same time. The situation is typical when there is left bundle branch block seen on the ECG. So if the patient has left bundle branch block with heart failure and having arrhythmia or having very low ejection fraction, they can benefit with this type of therapy. Nowadays, a new type of therapy has come, which is called as LOT CRT or left bundle pacing optimized CRT-D. So with that, the conduction system pacing is the type is what we discussed before, and that will be the fourth lead which will be here in that LOT CRT. Some evidence-based, life-based, which is the wearable defibrillator. There is a recent study in 2018. It has shown that there is no effect on primary outcomes, which was actually sudden cardiac arrest, but there was significant reduction in all-cause mortality, and safety was very good in this particular trial. But there is a recent study published in Nature. It was a real-world experience of 708 cases, which is a very big number for a wearable ICD. It has shown that there is a very good compliance, but it is lower in younger patients. Shock rates are 2.2%, and this is very nice to see that inappropriate shocks are only 0.5%. You have ICDs. ICDs have multiple trials, and all were positive for decreasing all-cause mortality and sudden cardiac arrest. Even the recent meta-analysis published in 2021 showed the same thing. But it shows that the rate of ICD is very low. That is mostly because of the awareness. So we have to somehow get the awareness part higher, so to increase the rate of appropriate use of ICD. And CRT-D again has multiple studies. The biggest study for versus the medical management showed 20% reduction in primary endpoint, that was sudden cardiac arrest and primary all-cause mortality. If you add CRT to ICD, then that also reduces mortality and hospitalization of heart failure. And it is useful even in non-ischemic cardiomyopathy, as is seen in this big study. It decreases both heart failure admissions and mortality. So to conclude, sudden cardiac arrest is an electrical problem of the heart, which is separate from heart attack. CPR or cardiopulmonary resuscitation should be learned by everyone. It can save lives. A survivor of sudden cardiac arrest should be thoroughly investigated for the cause and long-term therapy. And awareness for wider use of ICD and CRT-D is required to decrease overall sudden cardiac arrest. Thank you.
Thank you, sir. Now I would request Dr. Badhe sir to please felicitate, and on the behalf of Dr. Saurabh Deshpande, I would request Dr. Sarita Deshpande and Dr. Ajit Deshpande to please have the momentum.
सौरभने पण बघितला.
Now I would request Dr. Rajesh Gere, Dean BKC Jumbo COVID Center, Professor and Head Department of Forensic Medicine, Lokmanya Tilak Municipal Medical College. He has 25 years of medical legal consultant service, orator for medical legal talks on various national and international forums. And he's here to give a talk on consent and essential accord or savior.
So good afternoon, one and all. Let us now basically medical fraternity is well versed with consent, basic things. So we'll only go on the analytical aspects and what is practically feasible and required for any registered medical practitioner. So this, the topic what I gave is an essential accord or savior. Basically, we are mostly under misconception that once we take a consent, we are 100% protected by the law. So somewhere in this jingle of consent and defense of all this by a medical practitioner against negligence, in last 5 years, in various consumer forums, many of the consents are being declared invalid by the respective courts. We will be very specific instead of going in more definitions. What is practically implemented that we can see. Now definitions, most of the practitioners feel that consent is only for the medical people. No, it is basically Indian Contract Act. And you can apply this Indian Contract Act even in hierarchy of properties anywhere. So the legal practical definition, what definition we read in forensic books, Parikh, Modi, is something has been changed based on this basic concept. It is so easy when two or more persons agree upon the same thing in the same sense, they are said to be consent as per the definition of consent given in section 13 of Indian Contract Act 1872. So the gist of this consent is there has to be minimum 2 people or more, and they should agree at some point for something, and it should be at same sense. So this is where most invalidity of our consent. When we go to courts for deposing evidence as an expert for State Medical Consumer Forum at Mumbai for last 10 years, I am providing my advice to the forum. Same sense cannot be, we are very weak in writing and documenting how we take consent, in which we can derive that whatever information as a medical man is given to your patient is at same sense. So we'll just go in practical aspect. For the purpose of medical treatment, consent is granting permission by patient. It is only for the purpose of medical. Now, consent is not a one-off event of signature. So this we have to always keep in mind as a medical practitioner. आपल्याला सर्वांना हे वाटतं की हॉस्पिटलमध्ये 2 सह्या घेतल्या, सिस्टरच्या समोर विटनेस झाली आणि लिहून घेतलं की consent डॉक्टरांनी कळवले, डॉक्टरांना we are not against hospital and will not held liable for hospital and doctor याच्यात जर चुका झाल्या तर. So consent is not a single event on paper, but it is a process of communication. This is where we fail in law. We always think consent is only a piece of paper. No, it is a part of your communication process right from your patient arrives to your OPD till your patient is discharged from your ward. So it is part of that process. It's never a single piece of paper. Now this we all know, being an adult here, sound mind. Now what it reflects is the autonomy of each individual and right to self-determination. This, all citizens of our country has a fundamental right of self-determination and right of liberty under Article 90. So under this is enshrined. Now absence of consent may constitute tort of battery. आपल्याला बऱ्याच जणांना असं वाटतं की consent जर आम्ही घेतला नाही, the only criminal case under IPC 452, that is an assault on your patient, can be filed. No. The absence of consent, even law of tort, which is civil law, this is basically civil law, can be applied. In what senses? Now, according to some authorities, battery action could be brought instead of negligence in following situations. Some authority means the legal authorities, honorable courts, not the hospitals. Number one, patient consent to a treatment without understanding the basic nature and purpose of this treatment. Now, why we have written this? See, most of the time, when you are discussing and arguing in the court of law, the counsel of your patient will always argue that even though the consent is given by my patient, it was without understanding the basic nature and purpose of the treatment. And this applies more to rural areas and uneducated patient. They always have a defense की आता 10वी नापास आहे आणि डॉक्टरांनी इंग्लिश मध्ये consent लिहिलाय आणि they told us in English, सिस्टरने इंग्लिशने समजवलं, and now it means an offense under IPC 452 of an assault for that patient. No, such consent can be taken under civil law, that is battery of tort, not mandatorily be taken under criminal laws. Second, patient consent to one procedure, but another procedure is performed. See, many a time I can give you a basic example. When we open the abdomen, mostly surgeons, I would say, we will take a consent before procedure that we are doing exploratory laparotomy, say removal of appendix, basic procedure we look into. And once you open the abdomen, surgeon may feel, no, along with appendix, something surrounding intestine is strangulated or ischemic, and I need to tag it or remove it or to obstruct it. So in that time, what we do it in the betterment of the patient. but that the defense plea or the counsel of your patient may say that was not separately taken as per law. So that cannot be a criminal offense. That can be taken under battery of tort. Battery of tort means civil law, only compensation is afforded. Now, patient specifically refuses consent to a special procedure particular and the procedure is carried out. Now, sometimes we in anxiety, mostly in government hospitals, आपण सगळ्यांनी PG government hospital ला गेले, we always say in anxiety, ही मला procedure करायची आहे, and you try to take the consent of the patient, and patient may already mostly or the resident they say हे शिकाऊ डॉक्टर आहेत, यांच्याकडे आम्हाला करायचं आहे. And it doesn't consent on paper, and that minor procedure in the ward, resident may perform. And then if there is a UN crime, if there is allegation or litigation, the defense, the counsel of that patient will always file a criminal case against you in the police under 452. That is an offense of assault on the patient, but such consent can be taken under civil law. It is not mandated under criminal law. Number 4, patient gives conditional consent and the procedure does not satisfy that consent. Now this applies mostly to the literate patient. If you go in the corporate hospitals or even in the private hospitals of town where your patient is literate, and I can, when I go to Breach Candy, Hinduja, even that paid patient will deny treating from your junior RM. If he is paying for X doctor, who is one of the consultants for that hospital, he will say, "Mala Chinese bagitle pahiye. I am not paying for RMO SRA." So where we can apply this? Now a conditional consent for examination is given by your patient. And if you do not follow that condition, as well as consultant, Civil Candy, Hinduja, they don't have time to visit all hospitals. They have a junior consultant, I could say. Under that, they are also equally competent, may not be competent, but equally qualified. They will not be competent. In that case, he may say, "I round just put my note discussed on telephone." Nowadays, it is a fad, telephonic consultant, which law doesn't admit as of now. Telemedicine is, partly agreed by the court of law, but telephonic conversation and discussion and treatment solely on telephonic advice, as far as today's law is concerned, is not considered totally by the court of law. So there you can apply, you can say to the police or the court, this is not a criminal offense. You can file a complaint under law of tort or the civil law. What is a medical necessity? This we all know. Medical necessity means law gives you a privileged communication something. Upon second year, a definition was the privileged communication. So doctors as a fraternity are privileged if there is a medical necessity. Number 1 is medical emergency. There is a clear law in Supreme Court. If you are a treating doctor and if you feel that you need to operate or treat your patient within minutes, which will save the life of that patient, and by taking consent, if that life is jeopardized, then under medical necessity doctrine, there is doctrine of medical necessity, admissible under law. You can treat your patient for the life-saving procedures without any consent. Now, this is argument. Sometimes argument is that the unconscious patient, although unable to consent, would very probably consent to emergency treatment if he was able to do so, and so his consent can be applied. Now, where this we can apply? Take examples of trauma surgeons or trauma unit surgeons or emergency units in corporate hospitals. There you get a trauma case. Patient is not totally unconscious, but he can respond minimum to your commands. We can say, "Are dole ugar," he will open his eyes. It's not totally conscious. Now there is some argument in the court of law in such cases that consent was not given and doctor has taken treatment without the consent and some adversity has affected due to the procedure, and he should be booked under 452 or admissible criminal law. There what we take a different law. We can say he was responding to our command. It was an emergency. We just told him this is required. He nodded his head. See, these are all defense in critical times. That is the reason I told you this topic basically I made it not to discuss about the definitions of consent where we can practically apply in the court of law. Now, this is one landmark judgment, Arun Balkrishna here, where Sony Hospital is of Delhi, not Sion Hospital, of the Madras High Court, that in case of emergency situation arising during surgery, the doctor can proceed beyond the consent and do whatever is necessary. That is a settled law. You do not require consent at all. This one, I think, may not be known for treating doctors. Everything is known to you. These are all basic. So there is some section which is law of this country, 53, part 1 CRPC. This is regarding examination of any accused. We have a dilemma in my mind. Mostly of the private, they feel mine is a private hospital and me is high hospital. This is really absurd. There is no law, there is no JR of any state government except for conducting medical legal autopsies to an authorized sector. There is no such law or any court order which says a private nursing home cannot do this. The private nurse cannot so this is rarely used by the doctors, or we deny to examine any accused under 53(1) CRPC without consent. Even it is said in this CRPC, without consent, we can use reasonable force if the investigating officers agree to it. I mean, rape cases examining Sion Hospital is the center of this country. Nearby, we were first to have a one-stop crisis center in India in 2013. 2012, we implemented FOXO Act. I was one of the resource person for FOXO Act. And 2013, we started one-stop crisis center at Sion Hospital Casualty, which was first in this. We have many more defenses we should not fear. Now this, but first I will emphasize for all this treating doctor, we all feel that 18 years is mandatory for medical examination. Not at all. We have cited the section 89, 88 and 90 for purpose of clinical examination. Please read this line carefully. I am not saying that it is for the operations. For purpose of clinical examination, diagnosis and treatment, consent can be given by a person who is conscious, mentally sound, and is off or above. Off means at that 12 years or above that. You can consent for your clinical examination. No need of 18 years. It is already enshrined in IPC 88 and 90. We always fear, nowadays, because of consumerism, it's obvious because the way society is behaving with treating doctors, the fear concept is there. What we nowadays practice is a defensive medicine. So no need to fear. 12 years and above, if you are doing clinical examination, take proper consent. Proper informed consent, you are legally safe. No need of 18 plus and asking 25 varsha kadi zale, 18 varsha kadi zale. That is legally not required. A patient give it voluntarily, it is there. Patient has a capacity and competency and adequate level of this is basics of consent. Now these are all types of consent. We all know implied, express, informed, but nowadays in the prevailing situation of this law of our country and situation of medical practice in our country, it is always better to take a written, informed consent with full disclosure, no partial disclosure. You will land yourself with problem. We sometimes say, "He कळवल्याने त्याची चिंता वाढेल, तो उद्या suicide करू शकतं, किंवा he may be mentally depressed or suppressed." Don't bother. Save yourself. In this era, please take written, informed consent with full disclosure, no partial disclosure. Now, for this separate consent is mandated by law nowadays. In last 5 years, there are Supreme Court, High Court judgments. The categorically I have mentioned this condition, even though part of your examination treatment, आपण एक blanket consent घेतोच प्रत्येक हॉस्पिटलला 2-3 पानांची nowadays through software बऱ्याच AMC, CMC असे बऱ्याच संघटना आहेत, बरेचसे मेडिकल लीगल एक्सपर्ट तयार झालेले, कोणी डॉक्टरनी लॉ करायचं मेडिकल लीगल एक्सपर्ट बनायचं. गुड लक फॉर दम and they have devised all these formulas, प्रिंट काढून देतात 3-3 पानाचे कन्सेंट, गरज नसते. And we fail what is basic of law to be taken in consideration. Law doesn't presume की तुम्ही डिटेल मध्ये 4 पानं लिहून द्या, अजिबात नाही. When you stand for argument in the court of law, you go in the court, बसा argumentच्या वेळेस, they want basic things to be cleared from you. त्यांना बाकी काही जजला घेणं देणं नाही, त्यांना हेही घेणं देणं नाही तुम्ही एक्सप्लोरेटरी लॅबोरेटरी करताय आणि त्याचं किती डिटेल ऑपरेटिंग नोट्स लिहिलेले. Because he is not a man of medical science, he is a man of law, and when he is interpreting you for allegation against you, he will interpret you and your law based evidence based on law. So he nahi bagnar. No, many a time we ask our counsel and you tell the court 500 पानाचा इंडोर पेपर आहे, आम्ही सगळं डिटेल टाइम आणि हे क्लिअर केलं हे केलं, how this court is implying on us and this is your fault and this is negligence, this is error of diagnosis. No way. Basic legal compliance has to be done by us. आणि तिथे कुठेतरी आपण in anxiety किंवा improper guidance, I would say, not anxiety, cities मध्ये you may get a good expert.
2 minutes left. 2 minutes left, sir.
I waited morning. मी 11 पासून थांबलो यार. Sorry, cannot say. I will speed up as early as possible. Sorry. Sorry. Blood transfusion, separate consent. Anesthesia, separate consent. Operation and anesthesia do not mix the consent. Always please keep this in mind. Operating surgeon चा accountability वेगळा आहे OT मध्ये आणि anesthesia चा account. See, I have given more than 5,000 opinion of medical field in last 23 years of practice. And मोठमोठ्या corporate hospital मोठ्या नावाच्या विरुद्ध. There what we do, it is because of ignorance. It is not deliberate act. No doctor will do any deliberate act. That we all are sure. And court is also sure. The doctor कोणी deliberately चुका करत नाही. But he is compelled if there is no evidence in front of him. So take separate consent for operative, whatever you do operation, take separate consent by anesthesiology. फक्त 10 मिनिटं जातात आणि 2 पानं वाटतात, बाकी काही होत. But it will save from litigations. Different surgical procedures take separate consent. Do not mix your blanket consent. So this is blanket consent. It is totally invalid. मी पण सायनला कंटाळलो सांगून आमच्या क्लिनिशियन्सला. Still continued. पहिल्या पेजवर पूर्ण असं ब्ला 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 2 पानं लिहिली आणि लास्ट वी से की प्रोसिजर हॅज बीन एक्सप्लेन टू मी आणि ह्या प्रोसिजर मध्ये जर काही चुका झाल्या तर मी डॉक्टरांना आणि हॉस्पिटलला जबाबदार धरणार नाही. You have no right to take this. To be, there is a settled law. You cannot take a consent for committing an offense against any human body. So this blanket consent is purely an absurdity in the law. Now this informed consent is काय what is basic elements? We all know. I will only list what is 3 important cardinal component of consent is. Number 1, information should be full disclosure. Number 2, he has to voluntarily sign. And number 3, he should be in the capacity to sign. If he was not in the capacity to sign that consent, it becomes an invalid consent. Invalid consent in the eye of law is equivalent to not taking the consent itself. हे नाही म्हणू शकत की 3 मधून we have taken 2 component correctly and 1 we are missing, so दोघांचं 60% consider करा. There is no such. It's a various judgment. You all can get. Now informed refuse to treatment. See, this is what we can apply if we are doctor, you are treating smartly now. Informed refusal to treatment is allowed by. Now, but it is not in all cases. in which cases he should be competent to decide. Patient have anticipated and intended his decision to apply to the circumstances. Ultimately, so consequence of giving a refusal should be known to your patient. Third is there should not be any undue influence. If our महत्वाचे is very important. If there are any proof against you that there was pressure applied by medical fraternity, directly or indirectly, your informed refusal consent will be invalid. Then, even when his or her own life depends on receiving medical treatment, an adult of the sound mind is entitled to refuse. So every patient of yours, more than 12 years of age, has right to refuse your consent. Always keep jawab, balzabri. Even I will tell you beyond that, we are examining FOXO cases under CRPC 164 Part A. Supreme Court also cannot exercise compulsory right for examination to that victim, because it is under the against the right of liberty, which is enshrined by the Constitution. Now this is landmark Canterbury case related to consent. Samira Kole, I think we all know. Landmark cases in which consents were not taken and doctors Supreme Court gave principle related to consent. What was the principle given in Kohli case, which is given by Supreme Court? The doctor should seek and secure the consent of the patient before commencing the treatment. I'll tell this yesterday only. We had a medical legal conference in Nasik. I am secretary of MLA. There was one talk given by head of the department, PJ Medical College, one of my colleagues. The medical legal significance of operative deaths. Same questions were there. We deliberated for 15 minutes. Where is the law? The question was, where is the law which says how much time before I should take a pre-anesthetic checkup or patient fitness before operating? So this is the case. Supreme Court in Samira Kohli case has said that the doctor should seek and secure. Secure means आपल्या custody घे. Seek म्हणजे फक्त सही घेणं. Secure the consent of the patient before commencing the treatment. म्हणजे most of the time in public hospital, because of workload, we all know. One day before we take anesthetic fitness, one day before we take chest medicine physician, and he is posted next day. And the irony is that when he is brought to our OT, we say, "Ata OT full zali, माझा unit 2 दिवसानंतर आहे, you come." And same preoperative fitness is applied. Same investigations are applied. So that is not allowed by Supreme Court. Number 2, patient should have capacity and competence, that we have discussed. The consent should be voluntary, that we have discussed. The consent should be on the adequate information concerning the nature of treatment. That we all. So this is basics, nature and procedure. As we are out of time, will not waste time. Now consent should be specific. It should not be a vague consent. When I am operating appendix, you should write in that consent that I am doing appendectomy, whether it is partial, complete, along with that what is the risk of treatment. And what we feel nowadays, I rarely read consent in consumer courts. We do not write what are the alternative treatment. Suppose a surgeon is operating for appendix, it is mandated by the court whenever you do any procedure. Whenever you do any procedure, you have to inform to your patient what are alternative procedure available to you. Just like if Dr. Sajdev is doing a CT scan of, say, abdomen, take an example. Then he should mention that if I am performing CT of abdomen for XYZ indication, you can do USG also for this indication. Then you should say that if you do CT of abdomen for this indication, your diagnosis would be 90% correct or 90% beneficial to your treating doctor. And if you opt for the second line of treatment, say USG of plain abdomen, so accuracy of that diagnosis may be 70% for your clinician. This is where we feel to do. It's very tedious, but it is not impossible. See, basically we are we practitioners are in an era of legal war against medical fraternity. To be very frank, don't feel bad. If you see the number of cases in taluka courts also, leave aside city like Mumbai, there is exponential rise. In taluka courts also you see cases against doctors are increasing. And I will tell you, next 10 years after that, you will see consumer court local injection. There are reported cases, you do an intramuscular injection, obvious there can be reddening at the site, there can be some swelling. And you may ask him to apply ice, after 2 days it may subside also, resolve also. But cases so this is the condition of this country as far as the fraternities. Now this is where you should be very, very specific. Now where I can take common consent, yes. In few notings of Supreme Court, they have agreed to that doctors where you can take common consent. The common consent means single consent having 2 procedures or more procedures. Court has said there can be a common consent for diagnostic and operative, means you can take a single consent for diagnostic procedure also and operative procedure also, where if both the procedures are contemplated, if they are contemplated. Take an example of HRCT. In that, radiologist, clinician, a provisional diagnosis is that there is some pleural effusion. Take example this. I may not be clinically more correct like you, I am not a clinician, but I can give you a gist of that. And then you may say, you do HRCT or CT scan, and we will aspirate after that. Now, if these two procedures are contemplated with each other, dependent on each other. Second best example, doing angiography and angioplasty, contemplated. Nowadays, most of the cardiologists do that. So there it is allowed by the law, not in all separate procedures. In this, you can take a single consent, and you mention in your consent, these procedures are interlinked, contemplated or related to each other. There can also be a common consent for a particular surgical procedure and an additional or further procedure that may become necessary during the course of surgery. This is important for surgeon. Just same example, opening an abdomen. You plan for appendixectomy, and if you, before planning, if you starting your incision, if you feel that inside also I may get intestinal obstruction, that you can contemplate and take a common consent. Abdomen open झाला, बाहेर पळत येतो आपण, त्याच्या legal hair ला शोधतो. What happens, legal hair may consent you for the next procedure, interlink. But if your patient is more than 18 years, I have gone through 3 cases in Mumbai of such, then the patient himself will come out of surgical procedure and he will say, "Are मला का नाही विचारलं तुम्ही?" And if you say, "अरे तुझं आई वडील क्या legal hair पुसेवर येईल," त्यांनी सांगितलं होतं आम्ही सही घेतली, अरे I am more than 18 years. How can he consent for me? So असे पण issues होतात. So we should be careful in such cases. Now disclosure of information. I have told you there is no partial disclosure allowed for defense in the court of law in the trending nowadays laws. काही फोरेन्सिकच्या पुस्तकात भेटते नाही किंवा काही लीगल पुस्तकात तुम्ही some advocates may also advise this. In some cases like HIV, disclose पूर्ण केलं, उद्या he may go in depression, he may commit suicide, and मग तो suicide झाला, allegation may be made about abatement of suicide under doctor under IPC 306. काही गरज नाही. We have to take with full disclosure. And thank you very much. And secondly, one important point, always keep this in mind. Even though you take a written informed consent, I repeat, don't maintain just a written informed consent with full disclosure, and your consent is completely valid by law. And if that case is of res ispa locator, you know what is res ispa locator? Fact speaks for itself. If that case is under that doctrine, your complete consent may be legally valid, is considered invalid in such procedure. Better example, if ophthalmologist taking consent, complete legal consent for left eye cataract, operating right. It is a case of res ispa locator. 2 मिनिटं घेतो आम्ही 4-6 महिन्यापूर्वी सायनला केस केली. आय थिंक युअर सर्जन असतील इथे काटे कुठे सर कुठे गेले. गॉसिपियम आहे ना, मुवमेंट ऑफ स्वॅब. एक यूपीची केस यूपीला ऑपरेट झाली शारामपूरला आणि लॅप्रोटॉमी केली सर्जननी, क्लोज केलं, घरी पाठवलं. 2 महिन्यांनी पेन ऑफ एब्डोमेन सुरू झालं. तिथे एक्सरे काढले and as per their version that what we feel they align with us की त्यांना एक्सरे काही नाही भेटले काही नाही. आफ्टर फ्यू men pain worsened, मग त्यांचे कोणीतरी कुर्लेला नातेवाईक होते. They came to Mumbai, came to Sion Hospital. Again re-exploration was done. Before re-exploration at Sion, X-ray was done. It showed infected swab piece or gossypium, what you say. Then it was operated, but unfortunately infection was so enhanced in 5 months that that patient could not be saved by Sion Hospital. So it was brought for mortuary. And then we put our notes, this was the defense taken, gossypium. There are medical conditions in which you can voluntarily ingest a swab or gauze piece, and that gauze piece and swab piece can go out of your intestine and may be dislocated anywhere. So this is just an information to you. Because the rarest of the rare case, but there are chances. So thank you very much. Thank you IMA chapter. Thank you Dr. Kute for inviting me and taking the hospital. Thank you very much.
Only signature on paper is not sufficient. Communicate with the patient. पुरावा ठेवण्यासाठी पेशंटला कोर्टात कुठं तरी मला कम्युनिकेट केलंच नाही. आपल्याकडे कम्युनिकेशन आपण पेशंटला केलं याच्यासाठी आपण काय?
See, I said signature on consent should not be considered as a single procedure. It is part of your communication. आता corporate hospital मुंबईत काय करतात काही लोक, is what you are saying is true. They deny in the court of law. Nowadays they make a video of that patient and keep 2 disinterested witness. आपली चूक कुठे होती, आपल्या सिस्टरलाच विटनेस म्हणत. So she is not a disinterested. She is interested. There is conflict of interest. She is employed by you. So conflict of interest. So she cannot be a complete isolated witness. Nowadays, if you feel काही patient horrible असतात, we all know, we can judge की हा उद्या गोंधळ घालू शकतं, better way record करून ठेव. And you save that on any platform and you can prove as a court.
Surgery करण्यासाठी surgical consent, anesthesia consent. Third thing is the patient is medically unfit. We refer to the physician. Is that consent is also necessary? The physician should say that the patient can be operated.
Oh, the physician will send you fitness now. You are referring to physician for fitness. I could not get you. कशात मराठी सांगा तुझी.
Surgical consent घेतला.
Right.
Separately घेतला. असा physician चा consent separately.
For what? Unfit. नाही consent ची गरज नाही. Notes असतात ना physician चे. जसं प्री anesthetic fitness हा consent नाहीये. To send it to anesthesia department, they will write their notes and at the final they will say for this procedure patient is fit. Consent is not required. Physician ने लिहिलं ना, not fit and sign केलं.
Patient is fit under due risk.
Due risk ना, then the operating surgeon has to take a call in this. Now जेव्हा एक physician rider मारतो, with due risk, for which risky condition physician feels that whether it is indicated in your operation or not, the surgeon has to take a call.
Operate केल्यानंतर पेशंटला काही डेव्हलप झाली तर कोर्ट ऑफ लॉ मध्ये पेशंट काय म्हणतो ड्यू रिस्क केलेला असताना यांनी ऑपरेशन केलं.
ड्यू रिस्क डिफाइन करून घ्या ना फिजिशियन कडनं. नाही करायला पाहिजे. If I am a physician, if I am saying that he is fit or unfit, if he is fit with due risk, which condition under due risk? Write it down, no?
But question. The patient ने आपल्याकडे पेशंट आलाय पेशंट आपल्याला रिफ्यूज केलं कन्सेंट देण्यासाठी सिरियस कंडिशन मध्ये मग आपण आपल्या हॉस्पिटलला पाठवून दिला आणि तो रोड म्हणजे ट्रान्सपोर्ट याच्यामध्ये तो मध्ये गेला तर मग त्या आपल्यावर काय त्याच्यात लायबिलिटी आहे?
दोन लायबिलिटी लीगल बोलणार मी, सब्जेक्टिव्ह नाही बोलत. फर्स्ट इज दॅट if you are treating doctor and if you feel it is a emergency case, no need of taking consent, you do your procedure to save the life of patient, only to save the life of patient, बाकी काही नाही. Secondly, बऱ्याच वेळेस असं होतं की patient is coming without money to private hospital and you may feel ki I may need to spend 50,000, 1 lakh rupees for treatment and no one is available with him to pay my cost. For example, in that case, what Supreme Court has said, as a registered medical practitioner, leave aside whether you are surgeon, physician, or intensivist, as a registered medical practitioner, do first aid of your patient. Do first aid. If you require CPR, do CPR. A bleeding case is brought to you, say road traffic accident, arrange that bleed with whatever material you have, and then refer that patient to the nearest available facility. आपण काय करतो माहिती का सर, बऱ्याच वेळेस ट्रान्सफर मेमो आम्ही बघतो की फॉर एक्झाम्पल आपण शिर्डीचंच घेऊ, चला शिर्डीवर तुम्ही सिव्हिल हॉस्पिटल नगरला पाठवतो एक्झाम्पल, आणि मध्ये भरपूर रेफरल हॉस्पिटल आहेत ना. यू मे हॅव दॅट स्किल्ड हॉस्पिटल say in Pravara also, so you have to refer your patient to nearest available facility. कारण तो जो golden period तुम्ही म्हणताय ना, याच्यात why there is allegation of negligence against transferring doctor, because what law feels in this, when you are a registered medical practitioner, you well knew at the time of transferring of the patient that this patient may require this type of treatment within an hour, and you are referring to a hospital which is 2 hours from you. So that is your deliberate act. See, but then you may say the government hospital and private, leave aside now. You are referring doctor. What I feel, this procedure I cannot do at my center. This procedure can be done in nearest available facility at Rauri. Rauri will take say 40 minutes. I mean, giving an example. I will be technically incorrect also in kilometers. I have referred there. He may not admit, that is his concern. If he is not admitting as per your advice, then he would be punished under vicarious liability and contributory negligence. त्याचा विचार आपण नाही करायचा. बऱ्याच वेळेस आमच्या पब्लिक हॉस्पिटलला असं झालेले, बरेचसे सायन हॉस्पिटल, नायर, केएमजे मुंबईत काम करतात, ब्रॉड डेटच येतात आणि तिकडनं ट्रान्सफर मेमो असतो कळवा, ठाणा, नवी मुंबई, अलिबाग. म्हणजे अलिबागहून एक पेशंट रेफर होतोय सायन हॉस्पिटलला आणि आजचे रोजचे कंडिशन पाहिले गोवाचे 8 तास लागतील का 10 तास, नो वन कॅन गिव्ह यू इन ॲम्ब्युलन्स ऑल्सो, अँड यू आर अँटिसिपेटिंग की त्या पेशंटला फक्त 1 तासच जगायला आहे and you are sending to Sayan hospital which take 8 hours. So this is really absurdity. It is lack of your common sense application for saving your patient. And this is where court will say you have deliberately done this act, even though you are a registered medical. The printed is allowed under IT Act. It is allowed. फक्त printed ला काय करायचं ना सर, printed ला म्हणजे practically मी सांगतो. I'm not arguing. Some expert may say you can print it completely and take signatures only with the pen or written with the handwriting. But me practically माझा अनुभव सांगतो कोर्टात legal documents चे law आहे, legal IT Act खाली legal document आजकाल forgery of documents चा वेगळा law झाला की it is better की शेवटची लाईन तुम्ही हाताने घ्या. This is what I think to save yourself. एक लाईन म्हणजे आता I am ending with the consent. Above procedure, risk and procedures are explained to patient XYZ. This is this. He has voluntarily acted. 2 लाईन आपण बाकी टाइप करू नका. आणि हे जे तुम्ही म्हणताय ना, हे फिलिंग द ब्लँक्स फॉर्मॅट्स येतात ते एक्सपर्ट कडनं, ते मोकळे प्लीज सोडू नका. सगळं भरा नाही तर लाईन तरी मारा, आणि लाईन शुड बी अप्रिशिएटेड. ते असं डॅश 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 असलं नका करू प्लीज. कारण दिस डॉक्युमेंट आजकाल पेशंट इतका हुशार आहे ना, आय विल टेल यू. पब्लिक हॉस्पिटलला तुम्ही आज नोट सकाळी कन्सल्टंट टाकतो रेसिडेंट, अँड्रॉइड मध्ये लगेच कॅप्चर 2 मिनिटं. कितीतरी डॉक्टरांना मुंबईमध्ये फॉर्जरीच्या कंप्लेंट झालेले. We try to save them from negligence 304 part A and they land off. We change some documents na MRO वाले. And forgery मध्ये 492 खाली नॉन बेलेबल खाली घुसून जातात. म्हणजे जे म्हणतात मराठीतनं धुळ्यातनं निघून फुफाट्यात पडायचं तसं होते. So now we should be very careful. Patients are very smart and they record you everything.
You mentioned about 2 people should sign, signature should be on consent for a consent. But sometimes only one relative is there with the patient, then what?
No, I said 2 disinterested witnesses should sign. They may not be relative of the patient.
You are not available many times. Our staff is available.
This is for your safety. This is extra safety. Law only says consent, signature of the patient is required. But what happens? There are many reported cases in which this patient will deny it by giving some reason. की मी तर 4थी पास आहे, मला लिहिता वाचता येत नाही, डॉक्टरांनी म्हणे सही कर, मी केली. Then what you do? So this is your extra precaution.
Mentioned about patient should give consent, himself should give consent. But many times the relative tell us that disease is very serious. He will get into depression. So please don't tell him. We will give.
No, don't tell him. I told you. You have to take informed consent with full disclosure. Law is clear. त्यांना बघा प्रॅक्टिकल कम्युनिकेशन वेगळं आहे. यू आर ट्रीटिंग डॉक्टर, आपल्याला पेशंट आलेला असतो, यू हॅव टू ट्रीट. से पॅरेंट्स इफ दे से म्हणजे ते सांगतायत तेव्हा तो डिप्रेशन मध्ये जाईल नाही, काय करायचं काय देते तू पण सही कर म्हणायचं आणि आज जाऊन पेशंटची पण सही घ्यायची. तो त्याच्या जागी सुखी आहे. जसं आम्ही पीएम करताना आम्हाला एवढे फोन येतात, अर्धीच पीएम करा, हेच लिहू नका, तेच लिहू नका, बॉडी लवकर द्या. व्हीआयपी मोठमोठे हो म्हणतो, आम्हाला करायचं तेवढंच करतो आम्ही. So there are ways of means of communication. We have to be tactful now. You have to be a smart treating doctor, not a treating doctor. Nowadays in this era, you should be a smart treating doctor. Thank you.
Thank you very much. Such a nice talk. I request Dr. Vikas Golab sir to felicitate Dr. Dere sir. Dr. Mundana sir. To felicitate Dr. Dere sir.
Thank you so much, sir. Now I'd like to call upon Dr. Sangamnekar, sir. Dr. Sangamnekar, sir, is working at Colony Nursing Home, Pune. He is also a postgraduate teacher, and he is also a co-editor of magazine Satyayusha. I request Dr. Rajendra Chaudhary, sir, to chair the session. I request Dr. Bhushan Dev, sir, to chair the session.
Before I start my presentation, I request Kute sir, next time you change the pattern. First, Dr. Dere should deliver, and then Dr. Deshpande should deliver. After listening to his lecture,
I am getting palpitations. After the rich branches, we come to the Janta branch of gynecology. What is crisis? The crisis is doctor in dilemma, puzzled, panic due to perplexity of the problem. Now, what is complication? A complication is an acute or chronic term in the condition of.
Sorry to interrupt. I request Dr. Tangi sir to chair this session. So you can start.
Chronic term in the condition of the patient. What is complication? Complication is manageable, is expected, prepared, trained to manage, less displeasure in the patients, and sympathies towards the doctor. What is emergency? An episode which needs immediate treatment. Management is taught, learned, and practiced, and can tide over the situation. But what is the crisis? It's a severe form of complicated emergency. It's a flick of the nature, rare, not prepared, not taught, and twisted turns. Crisis complications of the crisis, exposed to outsiders, dependence on others, difficult to refer or transfer, beyond the control, legal liabilities, defamation and damages, bitterness, blackmailing, and ultimately unmanageable. So emergencies and complications are taught, crisis is not taught or it is not thought of. Now crisis involves fear and fright about the future of a doctor. Crisis may be individual, family, town, state, country, and world. I'll not go into the details of all other crises. Why consider the crisis? Because one should be prepared to fight, equipped for the crisis, army-like exercise in the hospital, save life or from the gynecologist, and also it is very rewarding. Gynecology is the only branch where if a doctor meets in the street, the patients acknowledge that to the boy that he has delivered him. And this is the only branch in the medical where the gratitude is more. Crisis in the Ovija practice, it is sudden, it is non-anticipated, unprepared, threat to the life, morbidity, and mortality. The crisis in Ovija practice might be obstetric, gynecology, neonatal, and social. Now, financial I will not cover. I don't think doctors are no more financially strong people. I can give an example. When there was a small block in the toilet of my hospital, so I called a person to remove that block in the toilet. He came, he put a rod inside, and the block was removed. Then I asked him how much money should be paid. He said 2,500. I said, look, I have practiced for 25 years, I am MD. Still, I am not getting that much money. How can I pay you? That person said me, doctor, look, when I was doctor, I was not also getting that much money. Antenatal, during labor, and post-delivery. Now, what are the antenatal? Big perforation, undiagnosed perforation. The relatives are lost, like sir said, to take consent and two consents and patient consent, everything is fine. But patient is brought in the hospital and relatives are lost. Teenage girls beyond parent, we have boyfriends. Believe me, after every fifth MTP I do, one is in the living relation. One is in the living relation. And then there is a problem of consent. Who is going to give the consent? The law might say anything, but ultimately who is going to give the consent? And there is also a law called POXO, which is really a dreaded law. So consent is a big problem. Pregnancy, which is continued after MTP. Antenatal crisis, missed FHS, stillbirths which are not diagnosed, or patient might say that 2 days back I had examined and you said everything is fine. Now how can my baby die? So stillbirth, sudden eclampsia, HIV positive patients, again, how to, sir again explain it very well, how to explain this to the patient, how would you manage, how would you explain this everything to the other patients that this patient is HIV positive? Can I keep that patient in the same room where the other patients are also kept? Late detected major abnormalities. During labor, severe fetal bradycardia, rupture uterus, especially after delivery, post-cesarean section delivery, cesarean hysterectomy, DIC, amniotic fluid embolism, and cardiac arrest. Now, these are the crises during labor. Postpartum shock and death in the bed. Crisis, neonatal crisis, anomalies which are not detected by sonography, asphyxia, aspiration, infection, and accidents. Now, crisis in gynecology, dense adhesions and there is no help. Only doctor and a nurse or whoever is assisting the doctor. Myomectomy leading to the hysterectomy. What should be done? Major operation started, but blood is not reserved. And need of the blood, but blood is not available. Genital cancer after hysterectomy, cystocele or rectocele after hysterectomy, pregnancy after laparoscopy and DNC for infertility, that is the pregnancy is continued after laparoscopy and DNC, fistula after the surgery, post-operative bleeding, forgotten sponge or instrument, sir has already explained that, burst abdomen, sinking patient and reoperate. It is very difficult to explain the reoperation, indication of the reoperation, and it becomes really a dilemma. Crisis, death and deficiencies, oxygen cylinder, lights off. Everybody should have generator in the hospital, that is a dictum. Now there was a hospital just around 90 kilometers from Pune. The lights were off, generator was started, and suddenly anesthetist got fainted while operation was getting performed. The assistant got fainted. Only surgeon was conscious, and after 10 minutes, surgeon got fainted. This has happened. It's a true story. So nobody could understand what happened, and then it was found out that the exhaust pipe of the generator was coming inside the operation theatre. Therefore, all CO2, carbon monoxide poisoning was happening, and everybody got fainted while the operation was going on. So planning of the generator, planning of the oxygen cylinder is very important. Life-saving drugs, manpower management, good communication, accidents occurring in the hospital, fall of the patient or a baby on the bed, trolley, cradle, aspiration cyanosis, burns due to the hot bag water. I don't remember which High Court has given the compensation, but compensation was worth 10 lakh rupees because the baby got burns because of the hot water. Especially the hot water bag is given to the spinal after the spinal anesthesia. Patient does not get any sensation of the hot water and patient gets burns. Drowning of the baby while giving the bath, delivery in the toilet or the vehicle. Now, unusual crisis, change of the baby, stolen babies, mismatched blood transfusion, fatal drug reaction, absconded patients, suicidal attempt by the patient. I have experienced 2 suicidal attempts in my hospital till date because both of the females, that patient got female. The husband was torturing her in the hospital, and two patients tried to commit the suicide. Crisis anesthetic death, operative death, medical and tubectomy death, which is the worst, and other. So what is the answer to this? There is no turnkey answer. Find out what is the genesis of the crisis. It is negligence, overconfidence, lack of knowledge, no desire to learn, lack of updation and renovation of the equipments. I'm extremely sorry to comment this. All these things happen usually with the experienced and aged people. Usually the juniors are more cautious than the experienced. Because of the experience, person becomes little overconfident. And therefore, this genesis of this crisis is more with the senior people rather than the junior one. Loose stocks. Again, there was a case in Pune itself. The patient was operated for hysterectomy. One sponge was not, the doctor, while counting the sponge, it was not, it was missing. So he just told to the sister that one sponge is missing, just find it out. She went outside and told to another sister that look, probably the sponge is, the doctor has forgotten sponge in the abdominal cavity. So you just find it out what is happening. The relatives heard that, and a lot of chaos happened in hospital. In fact, there was no such condition occurred, but because of the loose stocks, this occurs. Patient felt there is an injustice on them. When person goes into agony, there is misconduct. So what are the principles? Cool and calm my attitude, firm decisions, help the colleagues and seniors, refer if the facility is not available, do not delay the action, and reassess the treatment. Avoid irritability and anger because same questions are asked by the many relatives. So do avoid irritability and anger. Keep medical records. Involve the relatives. Produce confidence of the staff and relatives, and self-assessment. Medical management, surgical management, and manpower. I'll just go very fast. Now, medical management. Physician checkup. As per the law, sir, there is a might not accept me. As per the law, there is no necessity of physician checkup prior to surgery. It is the anesthetist checkup which is more important. Physician, if there is a medical condition, patient is having diabetes, hypertension, or any medical condition, then physician checkup is required. For the normal patient, there is no need of physician checkup. Only pre-anesthetic checkup is required. That too, not 1 day prior, it is not mandatory. Before giving anesthesia, pre-anesthetic checkup and documentation is required. Always IV line, blood cross matched, continuous monitoring. Rare drugs not normally stopped. For example, a drug called carbitocin, which is very newly available drug, which is not kept in the hospital. So such drugs should be made, at least one should be made available. Oxygen all the time, blood substitutes all the time. Moral should be always ready. Ureteric stent, one ureteric stent should be available in interstitial clamps and autoclave drum for laparotomy. Whatever might be the case, small procedure, one autoclave drum should be for laparotomy. Disposable gown and towel kits. Source of battery. Monitors, at least one monitor in the hospital. The manpower management, it is a teamwork. Rest to some. Do not they put all the people to work together. Rest to some. Relatives to work. Senior medicals for advice. Junior for the help. No holiday, compensate, that is later. But all staff should be available if there is a crisis.
From December, MPDC is for
High level of suspicion, how will you manage? High level of suspicion. Always consider that this patient will have a crisis. Anticipate earlier. Prepare for the worst. IV intracat for all deliveries and operations. Blood shape must match all the deliveries and medical. Every day check oxygen. Every day autoclave. Bi-weekly records. Weekly drug stock. Fortnightly instruments. And monthly staff drill. Moment and minute part with your alertness. Crisis prevention, consent, and I will not go into details. Blood forms, attending doctor's signature, signature of the patient condition, operation specimen, now when the patient always original copy to the patient in spite of their patient. Death, inform seriousness, don't serious patient getting treatment to the relatives. Say 2 minutes. Yeah. Confirm death. Avoid unnecessary treatment. Inform police if unknown. Postmortem is necessary. Extend all help for to move the body, ambulance, and clothes. Don't run away because there is a death. Death certificate should be given boldly. Visit relatives at the home. Don't charge will be a question mark. If you do not charge and show it in the bill that it has not been charged, it might be considered as acceptance of the but show it that it is received. You are not accepting that you have done any negligence. Legal call police police summons, sir has already taken that. I will not going to do. Only one. It's a case called Jacob Matthew. Everybody should know that case of Jacob Matthew, the case in Supreme Court. Where Supreme Court has protocol of how to arrest, how not to arrest a doctor. Must Jacob Matthews case.
नंतर लावलं होतं आपण वरची भरली का पडलं नाही ना हा नाही ते इतकं वाया जायचं ना कारण मी नुकतीच सकाळी लावली होती 11 वाजता 12:30 पाणी आलं
Must all the time whenever there is crisis, do not go run away. Involvement of all, conversation, and commitment. Newer concept, role of OBGYN ICU. It's a newer concept. It's a joint venture. Life-saving. At the same time, the duties are divided. Responsibility. Because patient is shifted to ICU. Efforts, effect, and economy share. Crisis extends the cost of the patient. Crisis expose the efficiency of the hospital. Crisis events and stability of the doctor. A crisis can be controlled and cured and crushed if you have confidence, courage, and conviction. I really thank sir for giving me the opportunity to give this lecture. Thanks a lot.
एकदाच फक्त दुष्काळात आम्हाला
Please restrict our speaker.
म्हणजे 2 वेळेला पाणी यायचं आणि एक छोटा तलाव होता हर्सुलचा त्या तलावाचं पूर्ण औरंगाबाद शहराला पाणी दिलं क्रांती चौकच्या पुढे तर काहीच नव्हतं औरंगाबादच नव्हतं म्हणजे बेगमपुरा तिकडे एक मकबरा वगैरे
Thank you, sir.
Thank you so much, sir. Now I would like to call upon Dr. Ritvik Chatterjee. Dr. Ritvik Chatterjee has completed MD Psychiatry from NAN Hospital, Mumbai. He has done his fellowship in child and adolescent psychiatry and is currently heading his clinic at Pune. I would like to call Dr. Prakash Barude, sir, as a chair. I would like to call Dr. Mundada, sir, as well to chair the session.
Yeah.
Thank you, everyone. Thank you, Secretary, for the opportunity. And thank you for the organizing committee as well. Okay. I'm not going to take a lot of your time. It will be just a 2 or 3 minute presentation. And this is not actually about psychiatry. However, what we do know is that since the pandemic, a lot of statistics has come up. We have been seeing a lot of statistics on mental health, that there is a possible mental health epidemic. It is how outlined by the UNICEF, WHO, all the possible organizations have came up with a acceptance that there is some kind of an epidemic of mental health coming in India. And not just in India, but everywhere in the world. So that's when I started to think, is it only psychiatric illnesses where we are seeing an epidemic? And that's when we see that whenever you look at things, for example, in diabetes, there is an increase. I'm sorry, I think. Yeah. Okay. Okay, so when we look at things like diabetes, if you ask an endocrinologist, the prevalence of diabetes is increasing. Prevalence of things like carcinomas is increasing. Prevalence of food allergies, prevalence of even cancer deaths is increasing all over the world, not just India. So when we started looking at what may be the common possible factors, what we are actually coming to is that there are a lot of common genetic factors whenever we look at all of these diseases. Now, there is a lot of cross-linking between depression, cardiovascular disease, things like allergic rhinitis, things like diabetes, even depression and breast cancer have been studied extensively, and we have been able to find a lot of common genetic factors. The main reason I want to highlight all of this is mainly because we as practitioners have always been looking at diseases from one specific symptom or one specific system. For example, a person of PCOD goes to OBGYN. A person of, say, inflammatory bowel disease will go to someone who is trained in gastroenterology. However, what we have now started to understand in most diseases and in most chronic diseases, I would say, is that there is a lot of common genetic origin. And that's what we are really facing whenever we look at actually any of the diseases that we call chronic diseases or lifestyle diseases, that each of us is basically facing one aspect of a common genetic disorder. Well, most of my images cannot be. Sorry, yeah. So this is a map of India where you're seeing all the different prevalences of diseases. This was in 2016, and this is before that. Okay. What I want you to also look at now, unfortunately, those images are not being displayed in this laptop. However, what you need to understand is whenever we look at the maps, similarly, of say diabetes, you're going to see this exact pattern. If you look at the maps of prevalence for hypertension, for breast cancer, for ovarian cancers, you're going to get a very similar picture. The only changes in the prevalence is mainly due to underreporting or overreporting at some cases. So basically, that comes to the point that I was trying to make is what can we do about this kind of an understanding? How many of us practice evidence-based medicine? Yeah, all of us. But how many of us realize that you cannot exactly follow the guidelines as given? The problem with evidence-based medicine is basically that we assume that everyone, for example, we take a drug, give it to 100 people, and we say that 70% of these people had this kind of a response. So if I give this tablet to you, there's a 70% chance that you will get this response. Makes a lot of sense. The only problem here is that we are assuming that everyone's biology is similar. And that's what we, as you grow as a practitioner, you start understanding that person to person variability in the way that they process things, in the way that they have different vulnerabilities is extremely common. And this is something which is increasing with age. Since I'm working mostly with child and adolescent population, to give you an example, if we look at the eldermost generation, the generations who are in their 60s right now, you will see that the difference between the tallest person and the shortest person is going to be the least. But if you look at the generation right now, who are in their say 30s or 40s, you will see much more variability. And if you're looking at the children who are in their 10s or 12s now, you will see that there is a much higher variability in height compared to the previous two batches. And this is similarly happening with every single disease. If you look at my parents' generation, you will see that there would be nobody who would have had a heart attack before their 40s or a diagnosis of something like slip disc. Now, you look at my batch, we are seeing people being diagnosed with these conditions in their 20s. And now, seeing adolescents and children, I'm seeing children at ages of 10, 11, 12, having a cardiac attack, having a slip disc, and including all of the other chronic diseases. That is the picture that we are currently facing whenever we are looking at the common children and adolescent population. So this is just one thing I wanted to bring to your mind so that you are able to understand that we need better coordination and we need better understanding of these multicellular, multisystemic genetic diseases. And currently our understanding is only that we are looking at one aspect of a end process of a lot of biological processes which are interacting with each other. So that was just the end of my PowerPoint presentation and my point as well. Thank you for listening. Yeah. So if we look at it, actually the point was not that the death rate is increasing, but the prevalence of cancer is. Yes, sir. Incidence and exactly. And this is something that we are seeing with each cohort. The older the cohort, the lesser amount of these issues. But the younger the cohort, the more amount of issues that we are seeing. And what we are seeing is that most of the chronic diseases that we know of, whether it is say something like cancer, different allergies, cardiovascular disease, diabetes, hypertension, or any of the psychiatric illnesses that we know of, all of these are now starting to increase much more compared to before. Yes, earlier ages. So, sir, actually, there are a lot of theories. The theory that makes sense to me is that since there was basically the advent of medical treatment for most of the diseases that we are seeing, we have kind of cut off natural selection. And now there are multiple combinations of genetics happening, which should not have been possible if there was natural selection. So what you're seeing is that variability is much more. To just give you an example, every child gets a genetic set from their father and their mother. But it's not the exact set. They get extra mutations on top of that. Otherwise, all the brothers and sisters would have been the same. Right? So they get extra mutations, and what we now understand is most of these mutations are not protective in nature. It's rare for a mutation to be protective in nature, and that's why we are seeing this variability. And that's why we will, this is something which is something we can anticipate as well. As and as the generations keep going on, you will see more and more of these chronic diseases come up.
Prevention first. Since we know the problem.
Yeah. So here actually I would say we are starting to see limitations of what we call lifestyle interventions. We always say yoga karo, 5 baje utho, do other things, right? But we are starting to see that a lot of these things are not very possible for most people, and it takes a lot of time and energy. However, what we do know is that there are things we know a lot of medicines, and these medicines, for example, are now being discovered to act at a genetic level. So these work as a gene promoters. For example, we just in the morning we had this talk about GLP-1 analogs. So you saw in that there were a lot of decrease in, I would say, severity of diseases, cardiac ejection fraction increase for people, weight decreased, right? So what we are now started to understand is that these medicines are actually working as gene promoters at a cellular level, and these genes which are usually switched on are genes which are responsible for repair, transport proteins, intracellular matrix, cell membrane protein, the receptors that we know. So once all of these things are being produced, the cell becomes a slightly more functional compared to before. And what we see is overall there is an increase in cellular function, and that is what we see with most of the medicine that we are talking about. So currently, whenever you talk about something like I would say antidepressants, something like fluoxetine, we used to think that it was because there is a drop of serotonin and we are giving something which increases serotonin. But my radiologist, for example, explains it in this way that it is equivalent to taking a very beautiful statue of a goddess and putting it in a tub of water. And जो पानी निकला, you are measuring it and saying कि पानी कम हो गया. So the whole point is that the medicines, whichever medicines that we are using, they do not only act at a surface level. They do not. So there are definitely medicines which act at receptor levels. However, what we understand is that there are multiple levels of actions, and a lot of medicines that we currently use are actually also working on gene expression. So you are seeing a lot of gene expression happening, which we are currently not aware of. So whenever you find a medicine which is showing you protective effects against many other diseases compared to the original disease that it is intended for, then you should think about whether there is a cellular level action, and you will most likely find that there is a cellular level action and there is a gene promoting action there. See, sir, I will give you an example. When I was in Mumbai, we had one patient. She had a very strong family history of breast cancer. It was ER positive, ERCA1. So what we saw was that her mother, her grandmother, and she had two sisters. All of them were diagnosed with breast cancer in their 20s. She had presented to us with complaints of depression and anxiety. We started her on medications. So we have been following up with her for almost now 15 years, and she has not yet developed any of signs of cancer despite regular monitoring, and she's in her 30s. To give you also an example, we are currently using fluoxetine as a gel for non-healing diabetic ulcers. So there's a lot of different medicines which are being used in many different ways. You will be able to identify these medicines by mainly seeing the alternative or increased quality of life that it gives. So whenever you see a drug which is giving you extra benefits, you're most likely looking at something which is working at a cellular level. And the reason that I took up this topic was to just expose all of you to this kind of a thinking. Just two things that you can take home from me would be, first thing, that you think of each patient differently. Try not to think of a person as someone from an evidence-based perspective. Try to think about how I can personalize, how I can make it a more precise kind of medicine that I'm working with. So this is something that we are starting to use. A lot of genetic history is something you can take. A 3-generational genetic history, for example, can not just give you the risk that the person has, you can also predict the course of treatment. And the personalization is to such an extent at this point where we are now able to see that there are a few drugs which work better on a few families. I'm sure this is something that all of us would have seen in our field, that you see a patient and you feel, okay, this patient will respond better to this drug rather than the first drug. And that intuition that you're getting is basically because you have been seeing enough cases, and you have seen enough cases to be able to identify that phenotype, which tells you, okay, this is that person is going to respond to this drug. Okay. So personalization is something which should be done. I feel it is very unfair if we treat all patients as the same kind of a patient. And the second thing that I would like to highlight would be think of cellular level or genetic level changes that drug do. And if you are able to find something which is giving extra benefits, you can use that as a life modification strategy. Just to give you an example, we currently know that whenever someone goes through something like depression or anxiety, the problem with the central nervous system is that it has the least healing power of all the cells in the body. So we talk about the liver and we say, okay, this can work for most of the rest of the liver. But in the brain, if there is a little bit of damage, it's very hard to undo that damage. However, what we are now seeing is that those people who are put on medicines tend to get features of dementia later. They tend to develop, for example, diabetes later. They tend to develop heart attacks later. And risks of adverse events in their life tend to decrease. So there is some, I would say, evidence, if not direct evidence, there is indirect evidence which does tell us that the medicine that we currently are using may have this role in preventive strategy as well. And it has a much better, I would say, performance compared to most of the lifestyle modifications that we currently work on.
So much, sir. Now I request Dr. Mundada sir and Dr. Garuk sir to felicitate our speakers. I request Dr. Rajendra Chaudhary sir to felicitate our chair.
सर एक मिनट त्यांना बोलव सर सर क्रॉस थोडं कर
जरूर सर जरूर
एक मिनिट हा परत ये टाका परत इकडे बघा
जरूर सर
बोलवलं जायचं होतं
There's a scientific session going on in the Godavari Hall. I request everyone to come downstairs. Thank you so much, sir.
खाली जायचं मग आपण